Good morning to all.
Hello, Dr. Ruchika.
Hello, ma'am. Good morning, respected chairpersons, eminent speakers, and delegates. A very warm welcome to all of you from Team Eficon 2020. Now we will start with our oral session of the day. We have very eminent personalities as our chairpersons. Dr. Pooja Sadana ma'am, Dr. Pramod Gupta sir, and Dr. Vidisha Vallabh ma'am.
Good morning, Dr. Ruchika. Thank you for the nice welcome.
Good morning, Pooja ma'am. Good morning, Pramod sir.
Institute of Medical Sciences and Research. She has many national and international publications. Ma'am has received Ma'am is Assistant Vice President of National Association of Palliative Care for Ayush and Integrative Medicine. She is a life member of IAPSM and registered with Epidemiological Foundation of India. And ma'am is a member of Indian Association of Palliative Care for Ayush and Integrative Medicine. Dr. Pramod Kumar Gupta sir is Associate Professor in the Department of Biostatistics, PGI Chandigarh. Sir has received his doctoral degree from Banaras Hindu University in 2002. Sir has received honorary degree of MAMS, MIA PSM and MIPHA from reputed academic societies. Sir has 41 peer-reviewed high-impact factor publications. He has carried out 16 research projects and guided 18 PhD, MCH, DM, MS, and MD theses. Sir has received 15 awards, fellowships from within and outside the country, like Young Biomedical Scientist International Fellowship Award, Young Scientist International Fellowship Award, Visiting Fellow at SAMSI USA, and Research Fellow at University of Texas USA, etc. Sir is an elected member of International Statistical Institute, Indian Statistical Institute, and life member of 17 other national and international academic and professional societies. Dr. Vidisha Vallabh ma'am is Assistant Professor in Himalayan Institute of Medical Sciences, Dehradun. She is MD Community Medicine from Himalayan Institute of Medical Sciences, SRHU, Dehradun, Uttarakhand. Ma'am has academic interests in general studies, environmental and occupational health, quality management, mental health, nutrition, and reproductive health. And ma'am is an avid bibliophile and poet, and she has received multiple awards in visual and performing arts. And she has also acted as Master of Ceremonies, organizer in various events. I am the session coordinator for this session, and I am currently pursuing my post-graduation in public health at AIMS Rishikesh, and I have worked as general dental practitioner for 2 years, and I have completed my bachelor's degree from Sudha Rastogi College of Dental Sciences and Research, Faridabad. Now, we will start with our presentations today. So our first presenter for the session is Dr. Poonam Yadav, who will be speaking on impact of mental health on antenatal and postnatal care utilization in low and middle income countries. Over to you, Dr. Poonam.
Good morning, everyone. Ruchika, basically, I'm not able to share my screen.
Ma'am, you have to share your screen. Option एक बार नीचे देखिए.
Yeah,
Share
there is an
screen.
option, but it is written here, host disable the participant's screen sharing.
Ma'am, 1 second.
Dr. Ruchika may share the screen, I hope.
1 second, ma'am. 1 second. Dr. Poonam, ma'am, please check now.
Yeah, I'm able to share my screen now. Good morning, everyone.
Good morning, Dr. Poonam. Good morning. Please go ahead.
Yes, sir. So, myself, Poonam Yadav, I'm PhD scholar at AIMS Rishikesh. This work has been done under the guidance of Dr. Surekha Kishore ma'am, Dr. Ravikant sir, and Dr. Rajesh Kumar sir. The title of my study is Impact of Health Intervention on Antenatal and Postnatal Care Utilization in Low and Middle Income Countries, a Systematic Review and Meta-Analysis. Full ANC is a term used to deliver 4 or more antenatal checkups, at least one tetanus toxoid injection with consumption of minimum of 100 IFA tablets, which helps to promote the delivery of a healthy baby to a healthy mother. But unfortunately, it is observed that a woman in low middle income countries has 120 times higher risk of mortality due to pregnancy and childbirth related causes compared to high income countries. Although intervention studies have shown the effectiveness of health intervention towards the maternal and child health outcomes, but due to their limited sample size, we plan to retrieve the relevant literature and pool the data for meta-analysis to evaluate the impact of health intervention on antenatal and postnatal care utilization in low and middle income countries. Operational definition of health we have applied. Any intervention designed with a mobile phone or smartphone to support the pregnant women and their neonates. It includes text messages, phone calls, and reminders through the apps to enhance the care of pregnant and postnatal mothers. We excluded the studies which used mobile technology for any other communication purpose or for a specific disease. The objective of this meta-analysis were to assess the effectiveness of health intervention on antenatal visits of pregnant women, on tetanus toxoid immunization of pregnant women, on compliance of pregnant women to iron supplementation, on postnatal visits of delivered mother. Data source we have used PubMed, Medline, Embase, Cochrane, Scopus, Sinhal, Clinical Key, Google Scholar, and Ovid databases. Meta-analysis was done in RevMan 5.4 software. P-value was considered less than 0.05. The effect of variable was measured in the odds ratio with a fixed effect model. This is the Prisma chart. After systematic searching of a literature, titles and abstract were screened by 2 reviewers independently with the help of Rayan software. The third reviewer resolved the discrepancy, if anything created related to the eligibility of the studies. After that, files were imported to the RevMan software. And finally, we got the 6 studies to be included in the meta-analysis. This is the table of included studies. The 6 interventional studies were included from the low middle income countries, 2 studies from the India. These are the results. This forest plot first is showing the comparison between the intervention and control group. It is showing forest plot favors the health intervention group with odds ratio of 1.81 with confidence interval 1.49 to 2.19. For tetanus TT immunization, forest plot favors the health intervention with odds ratio 1.63 with confidence interval 1.17 to 2.27. For outcome of iron supplementation, odds ratio of 1.88 with confidence interval of 1.18 to 3.00. Forest plot for the outcome of postnatal attendance of delivered mother. This is also showing the health intervention and with the odds ratio of 2.54 with confidence interval 2.15 to 2.99. And there is a funnel plot which is showing the publication bias and an effect estimate against its standard error for the outcome of the antenatal care utilization. This is the grade pro summary of findings table. This table has displayed the relative effect in odds ratio with the events per 1000 participants in each outcome. This meta-analysis concluded that mHealth has the potential to increase the utilization of antenatal care and postnatal care compared to standard care. Although the level of evidence is moderate, it might have a possible solution to enhance the accessibility of maternal and child health services to pregnant women and reduce the maternal and neonatal mortality as well. Thank you so much.
Thank you, Dr. Poonam. Now I will request our chairpersons if they have any questions, they can ask.
Hello, I just wanted to know, you used Ryan QCRL?
Yes, ma'am.
Oh, okay, thank you.
Yes, ma'am. For the screening of the eligibility of study, we two reviewers have used this RAN software.
I just
And for analysis of these studies, we have used the Raymond software.
Raymond. Okay, ठीक है.
Yes,
Correct, correct.
Dr. Poonam,
yes, sir.
may I ask one query?
Yes, sir.
You said you assess the impact of mHealth and you also compare. I might miss the, your early statement. You showed the compare, but you compare between what? mHealth
And control group, sir. Routine services and the
So-
standard care.
all
And
right, all right.
or the in comparison group, we have no exposure.
So you mean your meta-analysis papers pertain to the mHealth and the control group which have
Yes,
a mHealth, right?
No, sir. mHealth is an intervention group, and control group we have no intervention or standard care or routine services which are provided by the health workers.
All right. Thank you. Thank you.
Yes, sir.
Can we proceed, sir?
Yeah, please go ahead.
Now I would like to request our second participant, Dr. Nidhi Bhatnagar, who is going to present on the topic Stakeholders' Perspective in Menstrual Hygiene Management Among Adolescent Girls.
Who is this? Nidhi Bhatt.
Dr. Nidhi Bhatnagar.
What her registration number?
384, sir. 384.
384. Okay.
Am I audible?
Yeah, please.
Yes. Good morning, respected chairs. I'm Dr. Nidhi Patnagar, Assistant Professor from Maulana Azad Medical College, New Delhi. And I'll
Good
be
morning, Dr. Nidhi.
morning, sir. I'll be presenting on stakeholders' perspective in menstrual hygiene management among adolescent girls in resettlement colonies of Delhi. So this has been, I'll be just presenting the qualitative part of the study, whereas it is the largest study assessed menstrual hygiene practices among adolescent girls in urban resettlement colonies and rural slum in Delhi. So it had a quantitative and qualitative component, and the study was funded by National Health Mission of Delhi government. So suboptimal menstrual hygiene management is a major health challenge in low and middle income countries, and there is lack of valid information regarding poor accessibility and affordability of absorbent material, leading to poor menstrual hygiene management outcomes and increased risk of infections. Physical, social, and religious restrictions during a menstrual period are well known across studies. Lack of knowledge and practice in effective menstrual hygiene management undermines the academic outcomes, occupational, and overall productivity of adolescent girls. Stakeholders' perception regarding menstrual hygiene management is important, and thereafter this study was planned. So coming to the methodology, 4 districts out of 11 in Delhi were selected by a simple random sampling. We selected Northwest, Northeast, East, and South. And from each district, 1 urban resettlement colony was selected, again by simple random sampling. So altogether, we selected 5 resettlement colonies. And in them, the Delhi government dispensary or the primary healthcare center that was providing services, from that we selected 5 to 6 Ashas, Anganwadi, and ANMs, and 1 medical officer from each center, and we conducted in-depth interviews, and 5 focus group discussions were conducted with 28 teachers from 5 schools from 5 resettlement colonies, the closest school which consented for the study. I just didn't mention the study period was from March to December 2019. So basically, this project came from the Delhi government as a part of evaluation of Udan scheme also. So this Udan scheme was for the distribution of sanitary pads, free sanitary pads to out of school adolescent girls. So this Udan scheme was launched early in the year of 2019, and the project started in March. So data collection was started at around June 2019. So the project is entirely not focused on just on evaluation, but on assessment of overall perceptions of stakeholders. But yes, the evaluation of scheme also formed some part of the project, of the study. So the context on which the qualitative evaluation was done was: what do stakeholders feel about menstrual problem and its relation with health? What are the existing beliefs and practices regarding menstruation? What advice do stakeholders provide to girls for menstrual hygiene management? And what is the stakeholders' opinion regarding free and subsidized sanitary pad distribution? The results were organized into following 6 main themes: about menstrual problems as a health problem, beliefs and myths, advice regarding menstrual problems which stakeholders give, accessibility and affordability of pads from their perspective, adolescent males' view of menstruation in girls, and barriers in interacting with adolescent girls. And these were the sub themes identified: social isolation, dietary restriction, religious restriction, and school abstinence. We didn't use any software for analysis. It was just analysis through transcripts and thematic analysis of the transcripts. So coming on to the results, the first theme, menstrual problems as health problem for adolescent girls. Most health stakeholders, they recognize this problem of menstruation, and they reported the occurrence of symptoms during menstrual period, which adolescent girls complained to them. And school teachers reported increasing incidence of menarche in younger aged adolescents. So previously, it used to be around, they say it used to start around fifth, sixth class, which has now come down to third class. Even third class, they were reporting, some girls were reporting menarche. So that was a concern. And beliefs and myths regarding menstruation, social isolation was reported by majority of the stakeholders, in which they said girls should not go out, they should not go to school, not engage in fun and restrict outdoor activities. There was a misconception that if the girls engaged in physical activity during this period, it is likely to result in permanent restriction of physical activity. So that was a very strong myth that community had as perceived by the stakeholders. Dietary restrictions like touching pickle, cooking food in kitchen, serving it especially to the male family members was forbidden in many families as reported by the stakeholders. Religious restriction was also widely prevalent, and there was like not entering temples, not touching religious books, and not touching holy plants like tulsi. Practice of personal hygiene was also said that that myth was also there, and adolescent girls were not taking bath or washing their hands during menses. There were concern over adverse effects of using sanitary pads reported by stakeholders. One Ansha said that if the girls, so this was a perception of the stakeholders that that pad use was responsible for prolonged bleeding during menses by some girls. And most girls change pads only if they were soaked completely. And some girls also had misconceptions that pads cause cancer. And teachers said that many of the girls are not reporting undergarments during menses when they are coming to schools also. So regarding advice regarding menstrual problems, if we can see here, 66.6% Anganwadi workers and 73.3% ANMs were counseling adolescent girls regarding menstruation. But counseling was low from the ASHA perspective, because probably ASHA is not very much oriented on this topic. And similarly, if we say awareness to adolescent on problems related to menstruation, that is also very high in ANMs and in Anganwadi workers, and low in ASHA. Accessibility and affordability of pads was also checked. Recently, an Udan scheme was launched, so majority of stakeholders were participating in Udan scheme. So the scheme was like that: the pads were given to ANMs, and the point of distribution was once a week for every Wednesday through Anganwadi. At Anganwadi, the pad distribution used to be done, and ashas were involved in Anganwadi distribution along with Anganwadi workers, and they used to charge like ₹6 for one packet of pad to be given to out of school adolescent girls. So the main concern was the pad distribution should be made free, and emphasis was on quality. The quality of pads should be good, and there should be more number of quantity. There were only 6 pads that were being distributed. So the stakeholders said should actually be minimum 10 pads should be there in the packet, and Agarwadi also reported that community saying that we should go for free pad distribution. Now, like to tell something here that there are two modes of distribution of pads. One is in schools, the Department of Education is giving it, and through DOE, and that is given in all public schools of Delhi government. And other is this Udan scheme, which is covering outer school and adolescent girls. But we found that there are few sections of adolescent girls which are left from this bracket, and those who are married, those who are completed school, and those who are going to college. So those were the girls who were left from both of the schemes. So that was also reported by the stakeholders. And in schools, they said that distribution of pads led to increased sensitization and acceptance of male students of regarding menstrual hygiene management. So they were being sensitized and made they were accepting the distribution of pads, and they were more sensitive towards this issue of girls. So that was a good thing, as reported by teachers. And there were barriers in interacting with adolescent girls, like girls were shy, they did not wanted to talk, and there was they used to talk with their peers, as reported by the stakeholders, but not with the healthcare workers. And another issue reported by
Sorry to
Asha
interrupt
was,
you, Dr. Nidhi, but you are overshooting with the
yes,
time.
probably this is my last slide. And there were non-availability of working girls and no steps taken to address school absenteeism. School absenteeism was reported. Training of stakeholders on menstrual hygiene management, especially to ASHA and teachers, improve quality and quantity of supply of sanitary pads, all adolescent girls to be covered under free pad distribution, mechanism to dispel myths and misconceptions in the community through involvement of social media, and measures to address school absenteeism important. Thank you.
Thank you, Dr. Nidhi. Now, I would like to request our chairpersons if they have any questions.
Dr. Nidhi, you're very weird finding, because these stakeholders are nearby the Delhi area, right?
Yes, yes, sir. They are in the Delhi area only, providing
And
the.
they are school going kids.
So they are a mix of this. So this study is a part of the larger study. So in this it is only the perspectives of stakeholders. Now stakeholders are talking about two types of kids. One who are going to school. Teachers are talking about school going kids, whereas Anganwadi, A&M, and Ashas are
Okay, got
talking
it.
about dropouts.
Got it.
So
Got it.
yes, sir, both.
You talk about the simple random sampling of the selection of geographical locations, right?
Yes, sir. Yes, sir.
Is it right method to do the simple random sampling in this case?
Sir, we wanted to we wanted to have a non-biased way of selection of districts, and then the selection of urban resettlement colony.
It is not, implemented like a simple random sampling sense in that, but you should check with that. That is not, I think, a geographical selection is not, should not be done by the simple random sampling. That is the only remarks I would add.
Okay,
Okay,
sir.
thank you.
Thank you, sir.
Thank you, sir. Now I would like to invite our third participant, Dr. Tushar Prabhakar. He will be speaking on the topic health-seeking behavior among elderly suffering from non-communicable diseases. Over to you, Dr. Tushar.
What is registration number, Tushar?
Sir, 383.
Okay, done.
Hello, good morning. Am I audible?
Yes, Dr. Tushar, you are audible.
Okay. Good morning, esteemed chairpersons and colleagues. The topic for my presentation is health-seeking behavior and its determinants among elderly suffering from non-communicable disease. So, India is in a phase of demographic transition. The proportion of elderly is projected to increase threefold by 2050. With increasing life expectancy, the occurrence of NCDs becomes inevitable. So, health seeking behavior of NCDs, especially among the elderly, is an important public health affair and is an amalgamation of multiple determinants. So, here we seek to find evidence for these factors that affect the health seeking behavior of those geriatrics suffering from NCD. The objectives for my study were to assess the health seeking behavior in relation to common NCDs in elderly population aged 60 and above in Mehrauli area of South Delhi, and to assess how the determinants of health seeking behavior affect the appropriateness of it in the study subject. My study was a community-based cross-sectional study done in Mehrauli, which is part of South Delhi, Southwest District of Delhi, among elderly population who were 60 and above, were willing to participate and gave their consent, informed consent, and those who were not seriously moribund or bedridden. The sample size was calculated to be 350 after applying a design effect of 1.5 because our sampling technique was systematic random sampling. So here we chose the first house randomly, and thereafter every eighth house was visited to complete our sampling frame of 350 individuals. For data collection was coded, for data was collected and coded and entered in SPSS version 25. All quantitative variables were analyzed in terms of mean and standard deviation, while qualitative variables were analyzed through proportions. Chi-square test was employed for testing differences in proportion for utilization pattern between different groups, and a p-value of less than 0.05 was considered the cutoff for statistical significance. Binary logistic regression was applied to determine the independent statistically significant relationship between health-seeking behavior and its determinants. So we recoded these variables into binomial categories. So this table is showing socio-demographic distribution of our study population and its prevalence of NCDs among them. A relatively higher percentage of women were there in our study, probably due to the fact that they were the ones mostly available at home when we visited them. We can see that although the overall prevalence of NCDs didn't vary much between the two genders, a notably large proportion of men with NCDs were undiagnosed till before the study. When it comes to age, we can see that as the age progressed, so did the prevalence of NCDs, and all the oldest old subjects were aware of their illness. Those belonging to the lower strata of socioeconomic classification had a higher proportion of those with previously undiagnosed NCDs. Overall, we found that 87.4% of the study population was suffering from at least one NCD, and among them, almost a fifth were diagnosed during the study. I mean, they were previously undiagnosed. These bar charts are showing the appropriateness of health seeking behavior with respect to certain demographic and clinical social determinants. So, for appropriateness, we considered factors like timely health seeking from a qualified health practitioner and no loss to follow up. So, if you look at the first slide, we can see that a higher proportion of men, that's the green part, they had more inappropriate health seeking behavior as compared to the women. Similarly, in the second slide, those over 70 years had a poorer health seeking behavior. So factors like lack of social support and loss to follow up were some of the reasons in the oldest old geriatric population. In the third slide, those who were illiterate or educated only up to middle school had a notably higher fraction of those with inappropriate health seeking behavior. The last slide, we can see that those with duration of NCD less than 5 years, they constitute a bigger chunk of those with inappropriate health seeking. So people who had a duration of NCD less than 5 tended to ignore the disease until it was in full-blown condition. To summarize, we can see if we see the relationship between health-seeking behavior and its various determinants among those who are currently taking treatment, we find that gender, age, literacy level, and duration were independently significant factors that decided the appropriateness of health-seeking behavior. The other factors like socioeconomic class, availing of health insurance, presence of social support, and distance of preferred health center, although they were not significant, but they also showed a positive correlation with the appropriateness of health-seeking behavior. To conclude, even though almost all have taken some form of treatment, health-seeking behavior was found to be inappropriate in over half of them. So evidence suggested that women had a relatively better health-seeking behavior. The men, especially those who were still working, could make enough time for availing optimum health services as assessed. So OPD services during evening hours and holidays could alleviate this issue to some extent. It was also seen that with increasing age of individuals, the tendency to procure appropriate treatment felt lacking. So separate OPDs for geriatrics, separate queues at pharmacies, services delivery at home are some of the possible interventions for continued and timely follow-up. Level of literacy was taken as a proxy for general awareness. So it is important to use innovative IAC methods to create awareness. Um, and we should consider that also have to include people who are illiterate, because usually IEC activities like distributing pamphlets and all, they won't work with the illiterate population. So we have to use innovative methods. And those in whom the illness is still in nascent stage, it becomes important to ensure early and timely management. So for this, we can include grassroots level workers like ASHA in service delivery, like screening, investigations, and ensuring treatment adherence, so that we can stem the swift progression of NCD. Thank you.
Thank you, Dr. Tushar. Now I would like to invite our chairpersons if they want to ask any questions.
Dr. Tushar, I'm Dr. Pooja. I want to know what is the scale you use for calculating the socioeconomic status?
Kupuswamy scale, modified Kupuswamy for 2019 index, because the study was conducted last.
Okay. And how did you validate your questionnaire? What is the method you use for validation of your questionnaire?
It was a pre-designed question, and I did a pilot study among 30 individuals. So the questions were fitting, and with concordance with my co-supervisor, validated.
Okay. Any other method you use for validation?
Um, Probably we can use pre-existing questionnaires, but for my study we designed a questionnaire. We used some tools for the NCD assessment, like WOMAC scale for osteoarthritis, but overall it was validated through my pilot study.
Okay.
Hello, Dr. Tushar, Dr. Gupta, Pramod Gupta here.
Good morning, sir.
You mentioned in your in finding it is implicable to use innovative IEC method to create awareness. So
Yeah.
did you check anything like that in your data? Because I couldn't see, because actually anything you your data talked about the evaluation or awareness about that.
Yes, sir, because we found that as the literacy level among the illiterates, even knowing that existence of NCDs and how to go about it, they were lacking at that.
So this is your suggestion. This is not a finding, right?
No, sir, these bullet points are my suggestion how we can increase the awareness even.
Okay. There is one more thing I would like to ask. You selected the household, right?
Yes, sir.
And you selected the household. So I wonder if in one household there might be a chance that there are more than one people who are elderly, more than 60-year age.
Yes, sir. So for every 8th house we visited, if they had no elderlies, we visited the next house. And if
No, if in the house you have two elderly people.
So we randomly chose only one, because if we chose both, there would be a tendency that the health-seeking behavior would be similar. So it would.
So how you randomly select? Because if two appears before you, how you randomly select?
A simple random sampling. Mostly those households which had both husband and wife as elderly, we would toss a coin and allocate heads and tails. And similarly, if there were more than two, then
that is the theory. That is your statement. But there is a very technical. You select the household with the systematic random sampling. It is fine.
okay.
But I really need a very peculiar, specific methods by which you decide which person, male or female, you will select if you have a more than one individual, fulfilling your selection criteria.
The criteria I used was simple random allocation for the.
It is not a allocation, maybe, but simple random allocation. You can't do this because you don't know anything. You don't know any background information of that household.
Yes, sir.
Okay. Go ahead. Next.
Thank you.
Okay, sir. Thank you, sir. Now I would like to invite Dr. knows about birth asphyxia in rural Lucknow, a community-based cross-sectional study. Sir, her
Dr. Ruchika, you're not audible.
number is 82.
What is the registration number of Dr. Nitu?
Sir, 82. 82.
Okay. Dr. Nitu, go ahead, please. She is not audible, I think. Dr. Nitu, turn on your mic, please.
Dr. Neetu, please unmute yourself.
Dr. Neetu, you are not audible.
Hello. Hello. Now is it audible?
Yes, it's okay now.
Yeah, now you are audible.
Okay, sorry. The title for my presentation is what Asha and ANM knows about the birth asphyxia in rural India. As we can see that there has been decline in childhood mortality and neonatal mortality parameters of India over the years, but this reduction is comparatively slower in neonatal group, and perinatal asphyxia is the third leading cause of the neonatal mortality following preterm birth and sepsis. Now, most of these deaths are occurring within first week of life, and majority that is about 70% of them occurring within first 24 hours. Literature reveals that community health workers play an important linking role in linking the communities with the healthcare delivery system. So we decided to assess the knowledge and practices of ASHA and ANM regarding birth asphyxia, and we also decided to know if there is any association between their knowledge and practices with their educational level and total duration of services. For this, we conducted a descriptive cross-sectional study in 2 out of 8 blocks of Lucknow district. We have included Sarojini Nagar and Mal. The study duration was about 2 months in January and February month of 2020. All the ASHA and ANM working in these villages of Sarojini Nagar and Mal were included. Out of 150 ASHA and 60 ANM, 118 ASHAs and ANM were interviewed using a pre-tested semi-structured Hindi questionnaire based on the study material provided in ASHA Module 7. And as we can see here, that the total number of participants were 160. And here, and the majority of the ASHA and ANM were belonging to the age group of 26 to 40 years. And as you can see in the education, that definitely the ANM education were more educated as compared to the ASHA. And the majority of them were having working experience of up to 5 years. And we have explored their knowledge and practices based upon the multiple choice questions, and the participants were categorized basically arbitrarily into good and poor score as per their median score. The median score was found to be 5, and when they were asked about any training done in last 5 years, majority of the ASHA had undergone ASHA module training 6, 7. Few have done induction training and HBNC training also, and almost and only 20% did not had any training, whereas when coming to the ANM, they did not receive any training like SBA related to the newborn care. When we have observed their newborn resuscitation skills, and we have observed that they have been trained regarding various aspects such as drying, positioning, use of mucus traction and bag and mask. However, their skills regarding regarding the newborn care was found to be suboptimal. When we have when we also observed their practices, which was done related to the newborn care in those suffering with the birth asphyxia, it was alarming to see that the majority of them were practicing these babies to the newborn to the higher center. They were also practicing, that is, holding them upside down and slapping at their back, and only few were trying to help them resuscitation. When they were asked about the number of children they have seen suffering with birth asphyxia in last 5 years, a majority of them responded that they have not seen any cases. We, however, in the result, while data analysis, we found that there was no significant difference was found in the knowledge score between ASHA and ANM. And however, no association was also found between their increase in education and work experience with their knowledge. Finally, we concluded that the finding shows that there still exists a wide gap between the knowledge and practices related to birth asphyxia, and proper training of the healthcare worker is the backbone for successful implementation of any such program. And simple and small skill-based module highlighting their frequent refresher courses and helping them in supervision may need to be assessed for implementing this health newborn care program for the success of improving the neonatal mortality. And with these regards, I would like to summarize my presentation. Thank you. Thank you.
Thank you.
Yes, sir.
Thank you, Dr. Neetu. I would like to invite our chairpersons if they want to ask any questions.
I think we should go ahead if there is no question.
Okay, sir. So our next speaker is Himanshu. He is going to present on the topic stress and stressors among school-going adolescents, a cross-sectional study in urban areas. Over to Dr. Himanshu.
Ruchika, what his registration number? Dr. Ruchika?
So Vidisha here, it's 43.
Okay,
Yes,
thank you,
sir.
Vidisha. Got it.
Okay. Dr. Himanshu, please share your screen.
Can you see my screen? Hello?
Yeah, please go ahead.
So can you see my screen?
It's a blank. You move.
Dr. Himanshu, please share it again.
Yes, I'm looking for it. I have it on my mobile, but I can't share it. See.
Yeah, okay, you're sharing the Zooms. Okay.
Okay. A very good morning to all the respected chairperson and seniors. I'm going to present a study titled Stress and Stressors Among School-Going Adolescent, a cross-sectional study in urban area of Dehradun. So a little background. Today's adolescent group is tomorrow's nation's future, and it is most prone to stress and anxiety. Stress is a serious problem which can be detrimental to students and may result in bad academic performance as well as bad health. However, early recognition of stress in children can provide us with ample amount of time to intervene and thus eliminate the factors which are resulting in stress. This study is focused on the same. The aim of my study is to assess and The aim of my study is to assess stress and stressors among school-going adolescents in urban areas of Dehradun. Objectives are number one, to assess socio-demographic profile of students. Number two, to assess stress and various stressors among the students. And number three, to determine association between socio-demographic factors and stressors with stress. Uh, Material method used. A cross-sectional study was conducted in field practice area of Urban Health Training Center in Khurbuda, Dehradun, under the Department of Community Medicine of SGRR, IM, and HS, among the school-going adolescent who will be appearing in board exam next year, that is 2021. One of the school was randomly selected from the list of schools in the field practice area, and a total of 283 students in 9th and 11th standards were included in the study. So data regarding socio-demographic profile, different stressors, and level of stress was collected using a pre-designed semi-structured questionnaire, which was self-administered to each and every student who consented for the participation. Data was entered in MS Excel and was analyzed by using EpiInfo software, applying appropriate statistical method. Now coming to my findings, uh, table 1. Table 1 shows the distribution of the study participants according to socio-demographic variables. The variables were age group, sex, religion, class, that is standard, and type of family. Now, more number in age group, more number were, that is 56% were above 15 years, and there was male predominance. Almost 87% were Hindu, and 58% were from 11th class, and 65% were from nuclear family. Now, table number 2 shows the distribution of study participants according to different stressors. These are the 11 stressors I used, namely curriculum load, frequency of examination, too much work in some subject, fear of failing in exam, lack of extracurricular activities, fear of not living up to parents' expectation, family problem, financial problem, wanting to be more popular, loneliness, and relationship with opposite gender. इनमें से maximum number, that is 70% of the participant were stressed due to too much work in subject, and least number of participants, that is 19.4%, said that they were stressed due to relationship with opposite gender. Now coming to the figure, out of all of the participants, that is 283 participants, 41% were stressed, that is stress was present in 41% of the participants. So next table. This table shows the association of different stressors with stress among the study participants. Out of these 11 stressors, only these five were found to be statistically significant, and out of these five, family problem, financial problem, and loneliness were the most statistically significant. So out of 41 participants, 28 said that they have fear of failing in exam, 20 said family problems, and 25 said that financial problems are there, and 25 said they are stressed due to loneliness, and 15 were due to relationship with opposite gender. Next, to conclude, out of 283 participants, 41, that is 14%, were found to be suffering from stress, and there were majorly there were 5 stress factors, and more studies should be carried out to assess stress and stressors in school going adolescent, so that psychological counseling can be taken up to help those living with stress. Furthermore, studies will help in formulation of school mental health policies in adolescents, which can be incorporated in school health programs. That's all, sir. Thank you.
Thank you, Dr. Himanshu. Sir, his registration number is 43.
Okay, I have noted down, yeah, already.
Yeah, sir, our chairpersons can ask questions if they want to.
Dr. Himanshu, I want to know, you used EpiInfo for your analysis.
Yes, ma'am.
What is you didn't mention the version in your methodology. The version used for EpiInfo version used for your methodology for analysis. Sorry,
Uh,
you
Ma'am,
didn't
I
mention
used
the
it
version.
from my seniors. I used it from my seniors that laptop.
But you
So right now
must,
I'm
you should have mentioned the version you use for the analysis. Which version? So, and one of the objectives you stated was to assess the socio-demographic profile of
yes, ma'am.
adolescent.
To determine, yes, ma'am. To assess socio-demographic profile of students. Yes, ma'am. So socio-demographic, ma'am, age group, sex, religion, and type of family. These were the socio-demographic.
Is this the objective of your study?
Objective, ma'am. This is the objective. Students का socio-demographic profile assessment.
And for assessing the stress, did you
Ma'am,
use
general health
any?
questionnaire to
Did you use any scale for assessing the stress,
yes,
or
ma'am.
you didn't mention even any operational definition? You say extracurricular activities. What do you mean by extracurricular? I think you should have used some proper operational definitions. Family problem. How will you
Ma'am,
grade?
ये
फैमिली प्रॉब्लम किसको बोल रहे हो आप?
ma'am,
फैमिली प्रॉब्लम के लिए कोई ऑपरेशनल डेफिनेशंस होनी चाहिए. Did you use any
ma'am,
definition?
first of all, जनरल हेल्थ क्वेश्चनियर के लिए मैम वो स्ट्रेस के लिए जनरल हेल्थ क्वेश्चनियर 12 यूज करा था. स्ट्रेसर्स ये मैम जो बाकी स्टडीज से रेफरेंस लेके उनको स्ट्रेसर्स को लिया था.
Okay. You didn't use any
पुरानी
scale.
स्टडीज से
No.
रेफरेंस लिया था मैम इन सारे स्ट्रेसर्स का. जैसे करिकुलम लोड, उनमें भी फैमिली प्रॉब्लम्स उनका रेफरेंस लेके करा था.
नहीं, कोई ऑपरेशनल डेफिनेशन नहीं थी, जैसे एक्स्ट्रा करिकुलर एक्टिविटी किसको बोल रहे हो आप, किसको लिया आपने एक्स्ट्रा करिकुलर एक्टिविटी, या फैमिली प्रॉब्लम किसको
मैम एक्स्ट्रा
कंसीडर किया?
मैम
चलो ओके.
सिंपल एक क्वेश्चनियर बनाया था, उसमें लिखा हुआ था कि आर यू स्ट्रेस्ड अकॉर्डिंग टू करिकुलम लोड. उनमें यस और नो लिखना था, तो बस उनको डिक्टेट करा था कि करिकुलम लोड कि आपको पढ़ाई का ज्यादा लोड लगता है, और फैमिली प्रॉब्लम्स की घर की प्रॉब्लम्स, ऐसे उनको एक्सप्लेन करा था मैम पेरेंट्स को.
Dr. Sir, we should go ahead. I think let him do his
Okay.
work.
Okay, sir.
Thank
If
you.
you feel so, yeah.
Now our next speaker is Dr. Swapna Chaturvedi, and she'll going to speak on association of clinical and metabolic risk factors with NAFL, a case control study. Over to you, Dr. Swapna.
What is the enrollment number of Dr.
Sir,
Swapna?
1414.
दिव्या एक मिनट आना.
Sir, 14.
Thank you.
हाँ.
Thank you. Thank you.
शेयर स्क्रीन देखो कहाँ से. गुड मॉर्निंग. Am I audible?
Yeah, I
Yes,
can
ma'am.
hear you.
Yes, ma'am.
एक मिनट. Share screen. I have to open my PPT.
Wait. You have to open your PPT first.
Just a minute, please. Why is this happening? Okay. Very good morning to the chairpersons and all my respected colleagues. I hope you can see my screen now.
We can see your screen.
Sir, the topic of my study is association of clinical and metabolic risk factors with NFLD. It's a case control study. This study was done under the guidance of my supervisors, Dr. Neena Bhatia and Dr. Naval Vikram from All India Institute of Medical Sciences, and Dr. R.M. Pandey. NAFLD, or the non-alcoholic fatty liver disease, is the entire spectrum of fatty liver disease in individuals without significant alcohol consumption, ranging from fatty liver to steatohepatitis to cirrhosis. The prevalence in India is about 8.7 to 32.6%. The objective of my study was to identify the clinical and metabolic risk factors associated with non-alcoholic fatty liver disease. The formula for comparing two means with the statistical power of 80% and level of significance as 5% was the formula used for my cases and controls. So using the surrogate of body fat percent from the published Indian studies, a sample size of 160 per group was decided. This is the flow chart or the methodology for the study. A total of 320 subjects were, based on the inclusion and exclusion criteria, were selected for the study. 160 NAFLD cases were recruited and 160 controls were recruited. Data collection comprised socio-demographic factors, anthropometric and clinical factors, and parameters and biochemical parameters. Ultrasound was also done for all of them, and then data analysis was undertaken. The inclusion criteria for cases included adults of both genders between the age of 18 to 60 years, ultrasound proven fatty liver with or without histological confirmation in the past 1 month, and inclusion criteria for controls included individuals with similar age, gender, and BMI, and individuals not diagnosed to have NAFLD by ultrasound or histology. The common criteria was by questionnaire that the ongoing or recent, that is within the past 6 months, the alcohol consumption is less than 21 drinks on average per week in men and less than 14 drinks on average per week in women, as per the American Association of Study of Liver Disease practice guidelines. The exclusion criteria for both cases and controls included chronic liver disease and no history of the intake of drugs causing fatty liver, lipid-lowering medications like oral contraceptives or corticosteroids, the presence of type 2 diabetes, CVD, IBD, and the presence of other liver diseases, HIV infection, pregnancy, and lactation, positive test for the presence of hepatitis B surface antigen, anti-HCV bodies, and anti-HIV antibody. Ongoing or recent alcohol consumption if it is more than 21 drinks on average per week in men, and if it is more than 14 drinks on average per week in women in the past 6 months. Use of weight loss medications or participation in weight loss programs, and refusal to provide consent in the study. The data collection included socio-economic and demographic profile using a pre-tested questionnaire cum interview method. The anthropometric measurements by using the heightometer, weighing machine, measuring tape, calipers, the BCA machine, and all these equipments were standardized and calibrated. The clinical parameters included visual signs and blood pressure measurement. Biochemical parameters included blood testing using standard protocols. The association of the socio-demographic characteristics with NAFLD revealed that the upper socioeconomic group and the family history of diabetes had a significant positive association with NAFLD. When doing the regression analysis of the socio-demographic factors, it was seen that upper socioeconomic strata and family history of diabetes both had a significant association with NAFLD. The risk of NAFLD increased by 1.5 times in the upper socioeconomic group and increased by almost 2 times for NAFLD for family history of diabetes when both of these factors were regressed with other covariates of the study like age, gender, and BMI, and other covariates of the study. On comparing the measurements of body circumferences and central obesity between cases and controls, it was seen that waist circumference, hip circumference, MUAC, waist hip ratio, waist height ratio were all significantly higher in the cases as compared to the controls. Skin fold thicknesses were also higher in cases versus controls. The body fat and percent body fat were higher in the cases as compared to the controls. Similarly, the systolic and the diastolic blood pressure and the pulse were significantly higher in cases compared to the controls. The visual signs of buffalo hump, double chin, and xanthelasma were significantly higher in the cases compared to the controls. Doing the regression analysis of anthropometric and clinical parameters, it was found that waist circumference more than 80 centimeters for females and more than 90 for males had a significant association with NAFLD, and the risk for NAFLD increased by 8 times in both the models when adjusted for covariates. On comparing the biochemical parameters, it was found that fasting glucose, SGOT, PT, and the lipid profile were significantly higher in cases as compared to the controls. On doing the regression analysis, it was found that total cholesterol had a significant and positive association with NAFLD, when adjusted for age, gender, BMI, and other covariates of the study. So I will just conclude by saying that the metabolic risk factors, which is higher waist circumference and total cholesterol of the present study, can be incorporated as components of the health education program at the community level to educate people on the preventive strategies for NAFLD by adoption of healthy lifestyle measures. Thank you.
Thank you, ma'am. Now I would like to invite our chairpersons if they want to ask any questions.
Dr. Swapna,
Yes, sir.
may I request you to define your case and control once again? Who is the case and who is the control?
Yes, sir. So cases are those we have selected the male and female adults in the age group of 18 to 60 years, and the ones that were found to have fatty liver on ultrasound.
So
And
these are the
controls were the ones who did not have fatty liver on ultrasound.
But what is the background? The patient, the individual are coming from where?
So these were individuals who were selected from the OPDs of the medicine OPD and the gastroenterology OPD at All India Institute of Medical Sciences. And they were taken as and when they came, and they fulfilled the criteria for cases or controls.
I have a doubt on the control, because when you say control and you say that you tested them with the ultrasound and you found no fatty liver, right?
Yes, sir.
But the question is why you have checked with ultrasound? Why you have done ultrasound for those individuals?
Sir, ultrasound is the most feasible way of detecting NA fatty liver in the hospital setup, because although the gold standard.
Mike, let me rephrase my question. The question is that when the individual visited your OPD,
yes, sir,
there should be some reason to do the ultrasound, right?
Yes, sir. So these were I'll just explain. The controls were the healthy attendants of these patients who were fulfilling the criteria, and they were willingly giving their consent to become the controls, and just to they were willing. Their consent was given, and then they agreed to participate in the study. And when it was found on ultrasound that there was
now
fatty liver.
I got your answer. My query is that the right way to say this is the case control study? That is the pertinent question now come into the picture. When you define your control, the healthy group, can we say it is a case control study? That is my question.
So the controls were were the ones who had similar age, BMI, and gender, but they were not. I'm not saying that they were match control. They were similar in BMI.
This is not a case control study, Dr. Swapna. In my opinion, you should check it. Check upon this.
Sure, sir. Thank you so much for your suggestion. But this has all been done under the statistical guidance of Dr. Pandey from AIMS. So
I know Dr. R.M. Pandey. I have seen his name, but still I wanted to query. Maybe you are not answering correctly, or maybe there is some misunderstanding. If you see when we say control or case control study, let me put one line for you. When you say case control study, means we got the person who have all the similar background, means like the person, somebody like a case control, you do like a smoking related with the lung cancer. So you get all the lung cancer patient, and you just go back and you see who were a smoker and who were not. And that's how you define the case control group. So that similar study should be done like that. Is the similar circumstances should be define a case control study.
Yes, sir. Thank you so much.
This is two group comparison. One is the healthy individual, one is the NFLD.
Yes,
and that is the comparing you are doing. That is the right, but saying the case control will you lead so many complications, in my opinion. Perhaps you can re-verify with Dr. Pandey also.
Thank you so much for your suggestion, sir. Thank you.
Thank you, sir. Now I would like to invite the last presenter of our session, Dr. Sally Jadhav, who is going to present on the topic community mapping of COVID-19 cases admitted during April to June 2020 at the tertiary Registration number is 275.
Ruchika, I have a one Dr. Gorika Saxena. She has been replaced by this presenter, right?
Yes, sir. Yes, sir.
Okay.
A very good morning to respected panelists. Uh, the title of my study is Community Mapping of COVID-19 Cases Admitted during April to June 2020 at a tertiary healthcare hospital in Raigad district in Maharashtra, India. The prime When disease can travel so quickly, information has to move even faster. This is where map-based dashboards become crucial. Introduction. In December 2019, we all know there was a new virus called it was earlier termed as novel corona 2019 nCoV virus, and later on it was termed as SARS-CoV-2. It emerged in Wuhan, Hubei province, China, and then spread to other parts of China and other countries as well. In 2012 to 2014, MERS-CoV virus took around 2 years to spread and gain a population of 1,000 people who got infected. But SARS took roughly only 4 months to spread to the same number of population. SARS-CoV-2 coronavirus outbreak constitutes a public health emergency of international concern. Health professionals have long considered conventional mapping and more recently geographical information systems, that is GIS, as critical tools in tracking and combating contagion. The value of maps as a communication tool blossomed over the next 2 to 5 years in the series of understanding and tracking infectious disease as yellow fever, cholera, and in 1918 influenza pandemic. In 1960s, when computers geographic information system was born, the possibility of analyzing, visualizing, and detecting patterns of disease dramatically increased again. In this study, the community mapping of positive patients was studied, which helped us in concluding the viral transmission even during the first 4 extensive lockdowns implemented by the government and control measures taken at a hotspot and containment zones. Also, the study would help us in identifying geographical clustering of cases, if any, and could give further idea as to what to expect once the lockdown measures are released. The objectives of the study were to locate geographically the COVID-19 cases admitted during April to June 2020 at a tertiary healthcare facility, to study trend and pattern of geographical spread in neighboring area over the time period of 3 months, and to identify geographical clustering of cases, if any. Methodology used. Study type was observational cross-sectional secondary database study. Data collection, the study was conducted in MGM Medical Hospital, Kamote. The data was collated by existing surveillance and lab data records of MGM Medical Hospital, Kamote. Data sampling, universal sampling was there. So all patients who tested positive for COVID-19 by RT-PCR or gene expert technique were admitted to MGM Hospital, Navi Mumbai, Kamote from April 1st, 2020 to 30th June 2020. The inclusion criteria were patients admitted in MGM Hospital, Kamote from April 1st to 30th June. They should be tested by RT-PCR or gene expert, testing positive, and residing in Mumbai city, Mumbai suburban, Thane, Raigad district at the time of data of onset of symptoms. Exclusion criteria were none. Data analysis, quality control, and ethical considerations. So for data analysis, data was collated from surveillance hospital records, lab records, and entered in spreadsheet, Microsoft Excel using standard coding procedure. It was analyzed in Excel and EpiInfo if needed in SPSS. The necessary statistical tests were applied. Specialized GIS software was used for mapping to taluka level based on patient address using standard .shp files for local area. Quality control. The process of data correlation was supervised closely with all co-investigators using standard cross-checking methods. The director, MGM School of Biomedical Sciences, acted as a coordinator for data correlation. Department of Community Medicine conducted the study. The principal investigator and co-investigator acted as guarantors for the integrity and process of data collection to publication of results. Ethical consideration. The study proposal has institutional ethical committee clearance. So this is the observation and analysis that were concluded from the study. As you can see in table number 1, which is showing distribution of COVID-19 patient positive cases registered at tertiary care hospital, Navi Mumbai from April to June. We can see in Raigad, the highest number of cases were seen in Panvel area that has 622 cases, and total the Raigad district saw 839 cases. in Mumbai, the ward ME that showed highest number of cases, that is 14. Total Mumbai cases that were registered to MGM Hospital Kamote during April to June and were testing positive were 49. And similarly, from Thane district, Navi Mumbai region of the Thane district had highest number of cases, that is 48 cases. Total Thane district saw 80 cases. We can see the distribution in the graph number 1, which is showing frequency distribution of COVID-19 positive cases in tertiary care hospital. So Raigad district has the highest number of highest percentage of cases, that is 87%. This is the GIS mapping that was conducted. So we can see in the above section there is Thane map. Then we can see to the left of our screen, that is the Mumbai map, and towards the right of our screen, that is the Raigad district map. So this graph is showing maps of Mumbai, Thane, and Raigad with distribution of COVID positive cases. Each black dot that is seen is a positive case. So this is basically a coalition. The hospital MGM Kamote lies in Panvel region. Therefore, you can see a lot of clustering around in the Panvel region. We'll see the maps one by one. So this is the Mumbai map. This shows a map of Mumbai distribution of COVID-19 positive cases that were registered and treated at MGM Hospital, Kamote, Navi Mumbai. So you can see many cases were high concentration of black dots is there in ward M/E. This ward is the nearest to Panvel, so via distance wise, compared to other wards, for example, ward RN or ward GS. Therefore, we can see clustering in these areas. This is the Thane map. So in Thane district as well, we can see that Thane distribution of COVID-19 positive cases and maximum cases were seen in Navi Mumbai region. Again, Navi Mumbai region comes in close contact with Panvel region. Therefore, those patients were admitted and treated in Kamote Hospital. This is the Raigad district map. We can see that the highest clustering that is seen is in Panvel region with 622 cases. Now, in all these maps, we need to understand one concept, that is, even if there were other tertiary care hospitals present in Thane district and Mumbai region, still the case load that is there in the Panvel region tertiary care hospital is still comparatively higher. So therefore, this gives us a clear idea as to how much burden COVID-19 has caused on our healthcare system. Is that having really high quality tertiary care hospitals present in Mumbai region as well as in Thane region, still the high number of cases were referred to Panvel hospital as well. So discussion. The overall case fatality ratio is 6.9% globally, which is considered lower than that was reported during SARS, that is 15%, and MERS-CoV outbreak, that is
Sorry to
30.
disturb, ma'am, but you are overshooting with the time.
Okay, sorry. I shall conclude in a short way. So
Yeah, good.
yes. Uh, so there was a similar study which was done in Iran from March to April 2020. They also did GIS tracking, and there they showed that the capital in their city had highest number of cases. We also have WHO maps that are present, and a very famous mapping study which was done by John Snow in 1813 to 1858 during the cholera outbreak, which we all know has proven to be very efficient and effective. Therefore, understanding of the burden of healthcare system can be facilitated by GIS mapping facing treatment facility shortages. I would like to conclude by saying that modern GIS technology is centered around web-based tools, improving data sharing and real-time information to support critical decision making. It is not a question of if another outbreak will occur when and where. Viruses like SARS-CoV-2 know no country and continent boundaries. Therefore, for better preparedness, we need to keep tracking new outbreaks and promote further advances in mapping technologies. Limitations of this study were: this study shows local area limited to one hotspot, that is Mumbai and Navi Mumbai region. Therefore, national aspect is skipped, and data is showing positive COVID-19 cases reported at only one tertiary care hospital. A broader picture can be painted if COVID-19 hospitals, other hospital data is also used. These are the references. Thank you for your patient listening.
Thank you, ma'am. I would like to invite our chairpersons if they want to ask any questions.
Thank you.
Sir, are there any questions?
No, from my side. Thank you. Thank you, all the presenter.
None from my side. Thank you, sir. Thank you, everyone.
Thank you.
So now I take this opportunity to extend our most sincere thanks to all our chairpersons and our speakers and all the attendees who have joined us today from different places. Thank you all for your support and cooperation.
Thank you, everyone. Thank you very much.
Thank you, Dr. Ruchika. Thank you, everybody.
Thank you, ma'am.
Dr. Ruchika, can I leave now?
Yes, ma'am. Yes, ma'am.
Okay, thank you.
The session is over for the day.
Good morning, everyone. Sorry for the slight delay. I welcome you all on behalf of Team Eficon 2020 to the session, oral session number 9, non-communicable disease. I hope we have our chairperson joined. I can see Dr. Amanpreet, Dr. Bhavna ma'am, and Dr. Rashmi Kumari have joined us. So we'll start with the session. We have amongst us as a chairperson Dr. Amanpreet Kaur, Professor, Dr. Bhavna Langar, Associate Professor, and Dr. Rashmi Kumari, Assistant Professor. Dr. Amanpreet Kaur did her MBBS from DMC NH Hospital Ludhiana and MD Community Medicine from GMC Patiala, and she has also done postgraduate diploma in Hospital and Health Management from IGNOU. Presently, she is a professor in the Department of Community Medicine. Then we have Dr. Bhavna Langar, who has a teaching experience of more than 11 years. She is an associate professor in Department of Community Medicine, GMC Jammu. And we also have amongst us Dr. Rashmi Kumari, assistant professor, PG Department of Community Medicine, GMC Jammu. I welcome you all, ma'am. Now we should proceed with the oral session. And the first candidate we have is Dr. Sumitra Sharma, who will be presenting her oral session on the topic coping styles in women with depression, anxiety, and stress. Over to you, Dr. Sumita. Dr. Sumita, are you there? I guess she hasn't joined yet. Then we can have Dr. Neha Jetli, whose title is a cross-sectional study on prevalence of hypertension and associated risk factors among the elderly population. Dr. Neha?
Yes, good morning. Am I audible?
Yes, you are audible. Please start sharing your screen.
Is my screen visible to everybody?
Yes, ma'am.
Okay. Good morning, everyone. I'm Dr. Neha Jetli, second year postgraduate student in the Department of Community Medicine, Santosh Medical College, Ghaziabad. The title of my study is a cross-sectional study on prevalence of hypertension and associated risk factors among elderly population of urban slums in Ghaziabad city. Introduction. As we all know that elevated blood pressure is a leading preventable cause for cardiovascular disease and premature deaths worldwide. Advanced age is known to be a significant risk factor for high blood pressure. World Health Organization projects that two-thirds of the world's hypertensive population will reside in low and middle income countries like ours within the next decade. Thus, it will cause a huge additional financial burden. Therefore, an endeavor was done with the objectives to assess the prevalence of hypertension among the elderly population of urban slums of Ghaziabad city and to evaluate the risk factors associated with hypertension among the study population. The methodology adopted was that a community-based cross-sectional study was undertaken in the urban slums of Ghaziabad city, Uttar Pradesh. Elderly population aged more than 60 years were taken as a study population, and a self-administered pre-designed semi-structured questionnaire in Hindi was used for data collection. Study was undertaken over a period of 6 months, taking prevalence of hypertension as 49.5% from a previous study done in Delhi by Gonmi and Dwivedi. With a relative precision of 10%, sample size was calculated to be 392. A total of 395 individuals who consented were interviewed, and the residents aged more than 60 years of age from one of the urban slums, catered by the Urban Health Training Center of our own medical college, were interviewed until the required sample size was achieved. Approval from Institutional Ethical Committee was taken prior to the study, and the data collected was compiled and analyzed in SPSS version 16 trial. For the observations, as you can see in the figure 1, that 64.5% of the study population was in the age group of 60 to 70 years of age. 65% of the study population were males, 35% were females, and majority of them, that is 78%, lived in a joint family setup. In the socio-economic status, according to the modified Kuppuswamy scale, we found that 90% of the study population belonged to the middle and lower socio-economic status. The prevalence of hypertension in our study population came out to be 32.2%. And as you can all see, that 17.7% already knew that they were hypertensives, thus proving the rule of halves in this case. The people who knew that they were hypertensive, 88.6% were seeking treatment. The association between hypertension and age, we found that in our study population, major proportion of hypertensives were in the age group of 71 to 80 years. There was almost equal prevalence in male and females in the study population. In the socio-economic status classification, slight difference was seen in the prevalence of hypertension in the class 4 and class 5, but since the population is very less, it was not significant. It was also found that hypertension was seen higher in those who are dependent on their children, but again, the difference is not significant here as well. As far as modifiable risk factors were associated, we found that almost equal prevalence was seen in normal and overweight individuals in the elderly population in the study group. With alcohol, we found that there was a slightly higher prevalence of hypertension in those who were consuming than those who were not consuming alcohol. With smoking, we found that slightly higher numbers were seen with in elderly people who were smoking, that is 33.3% and 31.2% in non-smokers. With waist hip ratio in males, we found that hypertension was higher in overweight males as compared to normal weight males in this age group. In females, we found that females who were normal weight had less prevalence, slightly lesser prevalence of hypertension as compared to overweight females. So, in the conclusion, we can say that almost half of the study population did not know that they were hypertensive. They had no clue about their disease status. In this study, gender, socioeconomic status, and being overweight were not found to be the determinants of hypertension in the elderly. Raising awareness and regular screening activities must be undertaken for timely detection and treatment, as even modest reduction in blood pressure can benefit to a great extent in limiting the cardiac complications and thus premature deaths in this age group. These are the references of my study. Thank you for your patience.
Dr. Amanpreet ma'am, Dr. Bhavna ma'am, and Dr. Rashmi ma'am, if you have any questions, you can ask Dr. Neha.
Dr. Neha, I have one question, please. Am I audible?
Yes, ma'am, you are audible.
Most of the risk factors you have seen in this study, they are found to be non-significant. What could be the likely reason for them to be the non-significant, or what else you can have done to prove them to be the significant? As we know from the literature, majority of the factors, they were
Yes,
found to be significant.
yes, ma'am. As we know that these factors are found to be significant for hypertension.
Associated, but in your study, it's not.
Yes, ma'am, because the study was done in the elderly age group. So, as we all know, that as far as gender is concerned, in females over 50 years of age, hypertension is equally common as in males. Along with socioeconomic status in a developing country like ours, as we all know that it is associated to be linked with more of the affluent class than with the lower socioeconomic sections. But as the population is of the elderly, we found that it was almost equally prevalent in both the affluent and the lower socioeconomic groups as well. As far as being overweight and smoking and alcohol is concerned, that is the conclusion we came to, that there is a possibility that in the elderly age group, maybe this is not a factor, but the reason for that can also be the limitation of the study is because it was done in one slum only. So to extrapolate the results that we found in the general population is a little difficult.
Okay, thank you.
Thank you, ma'am.
Do we have another question, or should we proceed with the next one?
Hello,
Yes, ma'am.
Neha.
Yes, ma'am.
Am I audible?
Yes, ma'am, you're audible.
What was your research question, Neha? Dr. Neha?
Ma'am, the research question was to assess the prevalence of hypertension in the elderly population in the urban slums of Ghaziabad city.
Okay. And in conclusions, we have not written about the prevalence which you have found in your study.
Ma'am, I've mentioned the first point that the prevalence that we found was 32.2%.
But it should be there in the conclusion also, na?
Ma'am, it
It's
is said that
mean research question.
almost half the study population which had hypertension did not know about their illness. I mentioned it as
Okay.
my first point.
Okay. That's it. Thank you.
Thank you, ma'am.
So now we have Dr. Chitwan with us, and her title is to assess the mental health awareness and help seeking behavior of people in the rural areas of
Excuse me, ma'am.
Okay, you have changed your topic.
Yeah, ma'am, I have
I'm so
changed
sorry.
permission. Situation of toilet, bathroom, and kitchen facility in Shimla. Hello. Ma'am, can I start?
Yes, please proceed further. Please start. Your timer has started.
Introduction. Sustainable Development Goals. Goal number 6 have committed international community to avoid to expand international cooperation and capacity building on water and sanitation related activities and programs, and also to support local communities in improving water and sanitation management. India has made rapid progress in ending open defecation across the country, having huge impact on improving water sanitation and hygiene. WHO estimated that Clean India campaign could help prevent deaths of 3 lakh people from diarrhea and protein energy malnutrition. In 2015, around 568 million lacked access to toilets. Before Clean India campaign, only 39% of households had access to toilet. And World Bank supported national survey concluded that 10% of people in rural India defecated in open, and 96% of people who had access to toilet have used it. Promotion of community health necessitates providing clean environment, helping in breaking the cycle of disease. The levels of morbidity and mortality have led to losses in welfare that costing India's economy some 5.9% of GDP. Present study was conducted to know current prevailing situation of kitchen, bathroom, and toilet in Shimla city. Material and methods. Objectives of the study to assess prevailing situation of kitchen, bathroom, and toilet in Shimla city. In research approach, the study used principles of community participation and knowledge to action throughout all stages of research process. Study design was cross-sectional. Study area, Shimla city of Himachal Pradesh. Study period 3 months, July 2020 to September Study population. Population residing in all 34 wards under municipal corporation area of Shimla city. Sampling size. Sampling unit was households in MC area of Shimla city, and sample size is estimated to be 640. Sampling design was household selected by stratified random sampling, equal division in all 34 wards, 18 to 19 household per municipal ward was done. First household was selected randomly, and then every 10th household was selected to complete the sample size. Data collection was done through pre-tested standardized questionnaire administered in every selected household. First training was given to medical social workers and resident of community department, and then permission was taken from head of the family, and then questionnaire was started. The data was collected to obtain information on socio-demographic profile, knowledge, attitude and practice about wards, that is situation of kitchen, bathroom and toilet. Inclusion criteria: any adult person in selected household who had given consent, and exclusion was who didn't give consent and declined to answer the questions. This is table number 1. In which maximum respondents were females, 71.7%, 97% Hindu, 93.1% literate, and 37% were employed. 63.59% were satisfied with sanitation situation of India, Himachal, Shimla. In table number 2, 97.2% of respondents had toilet facility. 2.5% uses community toilets, while 0.8% went for open defecation. 58.4% use sitting type of toilet. 79% have toilet inside their home. 95.94% had toilets functional, and 4.7% had toilet related problems like flooding of toilets. 17.19% share toilets with other households. In table number 3, 89.1% had washing station at toilet, 72% had water basin at water station, 87% you had soap at station, and 96.3% had separate kitchen among them. 94.8% had smoke outlet in their kitchen. 94% respondent used cooking gas as fuel, and 92.8% had bathing facility at their homes. Among them, 98.4% had drainage system in their bathroom. Discussion: in our study, 0.8% practice open defecation, and 99.2% never went for open defecation. In a study done by Saroj et al., found 7% open defecation in urban areas of HP in 2 years back. Improved parameters may be due to implementation of ODF mission and better awareness in capital city. Study done by Saroj Rana found that 84% used LPG for cooking, 12% used firewood and chips, 3% used charcoal, kerosene in urban households. Percent of clean fuel use was higher in our study. Wash practices and facilities has improved over the time and is related to households' quality of life. Conclusion: improved kitchen, toilet and bathroom facilities improves health and hygiene. Clean cooking fuel and smokeless cooking can reduce load of NCD and communicable diseases. Such practices should be enhanced further. Efforts to achieve 100% targets for above mentioned basic amenities should continue, and equal importance to be given to maintaining already constructed structure under wash services. Utmost important is IEC activity regarding wash practices. Thank you.
Ma'am, any questions?
Hello. Hello.
Hello.
Dr. Chitwan, I'd like to ask you one question. Can you hear me?
Yes, ma'am.
You said that you had standardized your questionnaire. Can you tell what steps you had taken to standardize it?
Ma'am, this was a questionnaire taken from WHO, and then it was altered according to local situation.
Like what exactly did you do? How did you do your pilot study for this?
Ma'am, first there was some survey was going on, like medical social worker. They were collecting sample because here there was a outbreak of hepatitis A in 2017. So they were first trained, and situation of the city were taken into account. And then there was no as such a pilot project, but it was like a meeting 2 to 3 times with the medical social workers and administration and the counselor of the city, and then it was planned under permission of district commissioner and environment department.
I have one suggestion for you because you have done a very good job. If you had just added the morbidity condition also of these families, I think it would have worked much better in your study if you had shown that what kind of diseases they had suffered from. So we would have been able to compare those who were into open defecation and who had facilities of toilet in their houses.
Yes,
Okay.
ma'am. Yes,
Thank
ma'am.
you so much.
Thank you, ma'am.
Yes, hello. Am I audible?
Yes, ma'am.
Yes. You have taken sample size as 640.
Yes, ma'am.
Are they total number of people living in all the units of MC, or you have calculated the sample size?
Ma'am, there is 34 wards in municipal corporation area of Shimla. Expecting 50% of household has adequate knowledge about WASH. 95% was the level of confidence. Design effect was 1.5 and 5% confidence interval with 5% non-response rate. 18 to 20 household from 34 wards were taken and sample was around 640.
Okay, that's it. Thank you.
Thank you, ma'am.
Rashmi ma'am, do we have any question from your side or should we proceed further?
I think you can proceed further.
Okay, thank you ma'am. So next we have with us JB Jose and her topic is anti-diabetic medication adherence and the factors associated with the non-adherence in South India. Over to you, JB Jose.
Thank you. Good morning, all. The title of my study is Adherence to Anti-Diabetic Medication and Factors Associated with Non-Adherence Among Persons with Type 2 Diabetes Mellitus. Background: according to 2019 data, globally, 463 million people are living with diabetes. The prevalence in India is 8.9%. Good medication adherence is important for glycemic control, reduce complication, and to avoid adverse outcome. Public health sector hospital majorly caters economically weaker population, so it is important to know the medication adherence among this population, and such studies are rare from southern India. So with this background, we framed our objectives as among PWDs aged 18 years and above, registered on or before March 2018 and were on treatment for at least 1 year in a tertiary care diabetes clinic, Puducherry, South India, to determine the prevalence of medication adherence and to find the factors associated with non-adherence. Moving to methodology, we use hospital-based cross-sectional analytical study among all PWDs aged 18 years and above in diabetes clinic, which was run by medicine department during March 2019 to February 2020. We calculated sample size as 1002. Assumed adherence was 36% with the absolute precision of 3.6 and a design effect of 1.5. Among totally registered 2,500 PWDs, we selected 1,002 randomly. Pre-tested validated questionnaire were used. Moransky, Green, and Levin's adherence scale Tamil version was used to find the adherence. Modified BG Prasad's classification 2020 was used for socioeconomic status. Yeah. Informed written consent was taken from all the patients. Privacy were maintained. The operational definitions we used for adherence were MGL score of more than 2 was poor adherence, 1 to 2 was moderate, 0 was good. A MGL score of more than or equal to 2 was considered as non-adherence. Epicollect 5 up was used for data entry. Stata version 14 was used for data analysis. Medication adherence was summarized using proportions with 95% confidence interval. Log binomial regression was performed to find the adjusted prevalence ratios. This table is showing the percentage category of each social demographic variable. Age 46 to 60 years, male gender, rural residents, married, 1 to 10th class standard education, duration of diabetes more than 10 years, oral medication, presence of comorbidity, family history of diabetes were the higher percentages in these social demographic factors. This picture is depicting the prevalence of medication adherence. Good adherence was reported by 60.5% and poor adherence was reported by 10.3% with 95% confidence interval as 8 to 12.3%. This table is showing the socio-demographic factors associated with non-adherence. We adjusted those factors had a p-value less than 0.2 in the unadjusted analysis, and adjusted prevalence ratios were calculated. After adjusting for those variables, female gender had a 1.4 times higher risk of higher prevalence of non-adherence compared to male gender. Similarly, daily wage and agriculture occupation had more prevalence of non-adherence compared to their reference category. Tobacco usage had 1.46 times more prevalence compared to non-usage. Also, distance from diabetes clinic is more than those patients are not adherent to their medications. To conclude, non-adherence in this group is 39%, female gender, daily age workers, tobacco use, and distance to diabetes clinics from their home were associated with non-adherence. So we recommend healthcare providers to motivate or counsel the PWDs during every visit for good medication adherence. Thank you.
Any questions, ma'am?
Dr. JP, I have one question, please.
Yes, ma'am.
Your topic was very nice. Can I have an idea how you have taken these 100 patients out of all those patients which were being enrolled in the OPD?
Not 100, ma'am. We took 1,000 not 2 patients, ma'am. From
1,000 patients. How you have selected those 1,000 patients?
For in each every OPD, we went and we selected alternative patients when they were waiting for physicians. Every alternative patient, we assume that if you take every alternative patients, we can get around half of the total population.
Okay. What are the various statistical tests you have used to put for this adjusted odds ratio?
We calculated adjusted prevalence ratio, ma'am. We
Adjusted
used
prevalence ratio, sorry.
adjusted prevalence ratio. The log binomial regression was used for finding the adjusted prevalence ratio.
Okay.
For unadjusted analysis, we use chi-square test.
Okay, thank you.
Thank you.
Yes, Dr. JP.
Yes, ma'am.
You've taken assumed prevalence, I think, for sample size.
Yes,
assumed
ma'am.
prevalence. How you have taken that?
Ma'am, from southern India, from a public health tertiary care hospital, we did not get any study. From a North Indian state, we got so we took that prevalence as a prevalence for calculating this sample size.
Okay. Thank you.
Thank you, ma'am.
Yes, Dr. Jose.
Yes, ma'am.
You said it's an analytical cross-sectional study. So I'll suggest you that if you had finally made 2 groups, one who was into adherence and one who were not adherent, and then you had presented that table in which you have calculated all the associations, I think that would have been a better way of presentation.
Yes, ma'am. In this table, we have shown the total number here and the non-adherent. So the rest is those who are adherent only.
So if you had presented it that way, I think it would have made much clearer for the viewers also.
It's correct, ma'am.
Okay, thank you
I
so much.
accept it. Thank you, ma'am.
So now we have our next presenter, Dr. Ankita Tripathi, and her topic is prevalence of overweight and obesity among adolescent younger students in Gwalior city. Over to you, Dr. Ankita.
Am I audible?
Yes, you are audible. Please start sharing your screen.
Hello. Good afternoon, everyone.
Good afternoon, everyone. The title of my topic is Prevalence of Overweight and Obesity among Adolescent Younger Students in Gwalior. Introduction. Obesity has its major root in adolescent health in the last few decades. It is often felt that health of an adolescent is often neglected due to the lack of awareness, busy work schedule, and poor compliance from teens. The health consequences of obesity are many and varied, ranging from increasing risk of premature death to severe non-fatal. Debilitating complaints that have an adverse effect on quality of life. Adolescent obesity is a risk factor for later adult disease and it associates with impaired health. Considering the depth of this issue, this study was planned to find out the prevalence of overweight and obesity among affluent adolescents. Material and method include I taken study areas government and private school of Gwalior city, and duration of my study is 1 month from Jan 2020 to February 2020. It is a cross-sectional study, and sampling method is simple random sampling. My sample size is 150 students, and study population are aged between 13 to 18 years. Those who are absent from the day of data collection, they excluded from these studies. Further, I read that one government and two private schools were selected randomly from the list. Study instrument was questionnaire and physical instrument. A pre-tested semi-structured questionnaire was used to get information from the study population. The variable study includes details regarding socio-demographic factors, family history, physical activity, and anthropometric measures like weight, height, waist circumference, and hip circumference. Physical instruments were include weighing machine and measuring tape. After taking interview from the study population, all forms were collected and compiled. Data were entered into Microsoft Excel sheet. Descriptive statistics like frequency, percentage, measure of central tendency, measure of dispersion, and inferential statistics tests like chi-square test analysis were used. All necessary writing errors were sorted out accordingly. Observation and results. Prevalence of obesity and overweight of the 150 young people considered 20.5%, that is 31 out of 150 were discovered overweight and obese. 12 out of 62, that is 19.5% of girls were overweight obese, and 19 out of 88, that is 21.7% of boys were overweight. Statistically significant association was found between sex and prevalence of overweight obesity, that is P is less than 0.001. Prevalence and overweight according to the type of family. We found the highest prevalence of overweight obesity in class 13, followed by 11, and in class 10 that is 7, and in class 9. Sleeping pattern in obese, with respect to number of hours of sleep per day, the highest prevalence were found in study subject, that is 38.7% who slept for 8 to 10 hours daily. Of the 89 students study subjects who exercised, the highest prevalence of obesity was seen in 43.8% who exercised more than thrice in a week. Out of 98 study subjects who had snacks in between meals, 23 were found overweight or obese, and 75 were non-overweight, non-obese. And highest prevalence of obesity was seen in subjects who eating more than 2 snacks in between meal per day. Conclusion of my studies. In our study, majority of the students study subjects were aged 14 and 13 years as of end of class 11. Boys were participating more than girls in this study. The prevalence of overweight and obesity in more and who exercise daily and taking sleep of 8 to 10 hours per day. The factor contributing overweight obesity were male, sex, nuclear family, education in private schools. Also, prevalence are found higher in the subjects who took snacks in between regular meals. Thank you.
Ma'am, any questions?
Yes, Dr. Ankita.
Yes, ma'am.
In your title, you said that this is a study about adolescent younger students. Can you
Yes,
please explain which age group have you included this as younger students? And is it
between
standardized name or you have just incorporated it from your end only?
Ma'am, actually, I incorporated 13 to 18 years, that is the teenage students in my study.
And what is the group in which adolescents fall? What's the age group?
Ma'am, it's the teenage group, that is 13 to 19.
So you have called 13 to 18 as younger students.
Yes, ma'am.
Okay, there's one more thing I like to point out. You have said that you have taken details about the exercise, whether they used to exercise or not. So have
Yes,
you got
ma'am.
details of type of exercise, duration of exercise, or you have just asked about whether they are doing exercise or not?
No, ma'am, I have gone through detail that some are participating in sports activities, some are doing normal running and walk.
And
So I
about
asked them about them.
what about the duration?
Ma'am, around duration is 6, ma'am, between half hour to 1 hour.
Okay, so if you had presented this in the syllabus, I think it would have been better, because just saying exercise doesn't give a clear picture about the duration or just how much exercise they were doing. So this would have it would have been better if you had presented this part also in your study.
Okay,
Thank you so
okay,
much.
ma'am. Thank you, ma'am.
Yes, Dr. Ankita.
Yes, ma'am.
Can you explain how you have taken consent or assent from the students? From where have you taken the consent or
Ma'am,
for
actually,
conducting this study?
ma'am, actually, I prepared a list. I gone through district education office. Then I selected the 3 schools, 1 government and 2 private. Then at the time of their उनको जब मैम नॉर्मल रूटीन होता है उस टाइम पे हमने उनको बुला के और फॉर्म्स डिस्ट्रीब्यूट किए थे। तो जो भी विलिंगली पार्टिसिपेट थे मैम, वो उन्होंने पूरा प्रो फार्मा फिल करके दिया था, और जो भी मेजरिंग उन फिजिकल जो भी हमारे क्वेश्चनायर और जो इंस्ट्रूमेंट्स वगैरह था वो हमने अप्लाई किए थे उन पे।
Okay.
Yes, ma'am.
Your slides were not clear, I think, from this size, na?
Just a minute. Is it clear now?
Otherwise, it was good presentation. Slides were not clear.
Thank you, ma'am.
Dr. Ankita, I have one question, please.
Yes, ma'am.
Have you taken consent or assent both from the students as well as the institutional heads, or you have taken only from one person, from
No,
the
ma'am.
individual?
I taken from both institution head as well as students.
As well as the students. Okay.
Yes, ma'am.
So another question is how you have arrived at the sample size of 150?
Ma'am, actually, I selected 3 schools, 1 government and 2 private. I select 50 students from government and 50 out of each private school.
Okay. What was the criteria of selecting only 2 private and 1 government? You must have kept in mind.
Ma'am, actually, from recent study, I said that private students are more prone to getting obese and obesity-like features. So I selected 2 private and 1 government.
So I think no proper sampling technique has been adopted, the criteria.
Simple random sampling. I took out of 50 students, I took simple random sampling. But from the list I selected, I have to select 3 schools. So I got mixture of 3 schools.
Okay, thank you.
Thank you, ma'am.
Ma'am, should we proceed with the next presenter?
Yes, sure.
Okay, now the next one we have Dr. Sumita Sharma, and her title is Coping Styles in Women with Depression, Anxiety, and Stress. Over to you, Dr. Sumita.
Yes, ma'am. Am I audible?
Yes, ma'am.
This is not my slides. Can you please
Uh,
share my slides?
Ma'am, we are unable to see your slides.
Um,
Dr. Sumita, if you're unable to share your slides, can we share them from here?
Yes, yes, please kindly share my slides. I'm unable.
Okay. Okay, okay. Dr. Sumita, you can start with the presentation. I have shared your screen.
Yes, yes.
Ma'am, kindly start.
My study title is Coping Styles in Women with Depression, Anxiety, and Stress. Introduce burden of common mental disorders is presently demonstrating its horrible appearance among women in India. Henceforth, women with depression, anxiety, and stress are embracing distinctive coping styles to adapt to their issues. My study objective is to estimate the frequency of different coping mechanisms used by women with symptoms of depression, anxiety, and stress. The study design is a cross-sectional study.
Excuse me, Dr. Nandita, slides are not visible here.
Yes, ma'am, it's not visible.
Ma'am, are they visible now?
No.
No, they are not visible.
Ma'am, I'll check again.
Yes. The study population, all women aged between 18 to 45 years, that means reproductive age group women were considered, those who are residing in the slum under our field practice area. Especially, I have taken women, reproductive age group women from three slums. Three slums, and the women who were pregnant, who were diagnosed with chronic illness or disability, major mental illness like schizophrenia, manic depressive psychosis, those were excluded in this study. Study sample, I have taken. I have taken 190 from 190 household, 252 women. As for conveniently, I have found, and the study period, it was conducted from July 2020 to November 2020. Next. Next slide.
Ma'am, I guess even we are having some issues over here, connectivity.
Then study instruments, coping strategies, inventory short form, which includes 16 items, and those are evaluated in the forms of problem focused, emotion focused, and avoidance styles. In this questionnaire, the subject answer each item in 4-score Likert scale, as never is 0 and seldom 1, often 2, very much 3. The depression, anxiety, stress scale, dash 21, which includes 21 items that evaluates each of the psychological structures of depression, anxiety, and stress by 7 items each. And the way of subjects answering to each items in 4-score Likert scale, never 0, a little 1, sometimes 2, and always 3. In this research, those who obtained scores above 14 in related to depression, and those who got scores above 10 related to anxiety, those who got scores above 19 in answering the items related to stress, are considered respectively as being depressed, anxious, and under stress. So coming to the my results, I have found that I have divided the samples into 5 groups: depressed, anxious, under stress, combinedly depressed, anxious, and under stress, then normal population. Among those, in depressed group, the problem focused coping styles is maintained by 51.63 plus minus 12.32. In this table, I have found that in all group, the problem focused coping style is adopted by maximum of the people, maximum of the women, and then it is emotion focused, which is next to it, 20.16 plus minus 3.82 standard deviation, and in anxious group, emotion problem focused was 54.17, and emotion focused was 21.93. Like this, in this table, I have found the problem focused coping style was adapted maximum. Next slide. To check whether the problem focused or emotion focused or avoidance styles, that in these three coping styles, they are normally distributed or not, we take it in Kalmograph Smirnov test, and we found that yes, those three coping mechanisms are normally distributed in the population study sample. Then then we put MANOVA test here, and found that each group is significantly different from each other, with the Wilks lambda value of 0.835, and here p significantly, that means 0.002 is the p value. So these 5 groups, normal, depressed, anxious, under stress, and compound, these 5 groups are significantly different. So how these pipes are significantly different from each other? Next slide, please. Then we tested here the post hoc analysis. Toki test is done, and here we found that in the emotion focused in the emotion focused coping style is adopted by the compound, and normal group is significantly different, which is 0.023, and same as avoidance coping style is also significantly different from compound and normal group, which is 0.001. So in my conclusion, I have to say there is a significant statistical difference between compound group and normal group in applying emotion focused coping style and avoidance. The first group, that is mixed group, applied to coping style of emotion focused and avoidance more than the second group, that is the normal ones. There is a difference among means, less or more, but this mean difference among 3 groups regarding coping styles of problem focused, emotion focused, and avoidance is not statistically meaningful. That means the groups of depressed, anxious, and under stress have no meaningful statistical difference regarding the coping styles. Therefore, it could be said that 2 coping styles of emotion focused and avoidance style could play an important role as intermediate or one of the effective factors in the individuals in establishing negative effects such as depression, anxiety, and stress. Thank you, ma'am.
Dr. Sumita, can you repeat your objectives of the study as the slides were not visible initially?
Ma'am, to establish the coping styles among the women, those who are depressed, anxious, and stressed, under stressed.
Okay, what could be the possible limitations of your study, as this is the convenient sampling which you have taken?
Yes, ma'am. There is the total slums are 13 slums in our field practice area, but I have taken only 3. So it is not to be generalized. It is a limitation, ma'am.
Okay, thank you.
Dr. Sumita,
Yes, ma'am.
you have said you have taken your subjects as those having depression, anxiety, and stress, and you have shown that these had almost same kind of coping styles.
Yes,
This
ma'am.
is what you have presented. Okay. Now you tell me the subjects you had taken were those having depression only, anxiety only, stress only, or they had combination of factors. Please, it was not clear from your tables.
Yeah, ma'am. Combination of others also, and some confounding factors like are also there, ma'am.
So what I mean to say is those who had depression might be having anxiety also and stress also.
Yes, ma'am. There may be, but in questionnaire, das questionnaire, what they feel, according to that, I have grouping it and depressed or anxious and stressed like this.
Actually,
According to
my
their answer.
my advice is if you had shown only those who had just depression, just anxiety, just stress, and those who had combination of these three factors, I think then it would have been much clearer for us to understand what are the coping factors which are playing a role. Because this might have been a reason that your results have shown similar coping styles in all the three groups. Okay,
Yes,
so to analyze it in that way also and try to see if some differences come in your results.
yes,
Thank you.
ma'am. Yes, ma'am. Thank you very much, sir.
Yes, hello, Dr.
Hello.
Sumita.
Yes, ma'am.
All the limitations have been discussed, but I want to say something that your slides were too full of text.
Yeah.
It was
Yes.
not very impressive, so otherwise good. Thank you.
Yes, ma'am. Thank you, ma'am.
Ma'am, do we have any other questions?
No, I think we can proceed.
Uh, then we are done with the sessions. We don't have any more presentation. Thank you so much, Dr. Bhavna ma'am, Dr. Amanpreet ma'am, and Dr. Rashmi ma'am for chairing the session and sparing your valuable time. Ma'am, we have already shared the link for the Google form. Please kindly evaluate the presenters and send back the feedback. Thank you so much for being with us and sparing your valuable time. Thank you so much, everybody.
Thank you so much. Thank you.
Thank you, Dr. Nandita.
Thank you so much. Ma'am. The session for NCD has ended. Another session will begin shortly. You people can join or you can join another session. Thank you so much.
So can we leave Dr. Nandita now, please?
Yes, ma'am, you can.
Okay, thank you.
Thank you so much, ma'am.
Everybody, a warm welcome to all of you. I'm Dr. Joyita. I'm the coordinator for the next session. We will be starting the session.
Very warm welcome from AIMS Rishikesh to Eficon 2020 National Conference of Epidemiological Foundation of India. So this is the 11th session of the oral presentations we will be having. I welcome to all our respected chairpersons. All the participants are here. debate chairperson today. I am your coordinator. I am the coordinator, Dr. Gayatri Saxena. After 2 days, I was practically in class also to Bihar National University. I'm now pursuing MPS from AIMS Rishikesh. Now we have in the main panel, we have Professor Nasir Nawaz, sir, Professor Head of Department of Medical College. Mathura, he is a great renowned person in the Department of Community and Family Medicine. We welcome you, sir. Next, we have Dr. Dinesh Kumar Wale, sir, who is Associate Professor at CPL. I welcome you, sir. Next, we have Prakash. मैम आगे बढ़ा लो प्रेजेंटेशन We have Dr. Dinesh Kumar Walia, sir, with more than 30 years of regular practicing experience at Prayagraj, Telangana, Chandigarh, and Office of Indian Army as Captain Famous in Allahabad. Sir, we welcome you. Next, we have with us Dr. Ravi Prasad Verma, sir, Associate Professor of Epidemiology, Shri Federal Institute of Medical Sciences and Technology, Trivandrum. Ravi, sir, we really welcome you and hope we all have a fruitful session. So, sir, with your kind permission, can we start with the proceedings of the session? Hello? Am I audible to everybody now? I'm really sorry. Am I audible now? Now I'm audible to everybody. Hello? Am I still not audible to people? I would require, we just need 5 more minutes. There's a technical issue. We need 5 more minutes for there's some technical issues. I'll apologize for that and we'll resume that. I apologize, Syed sir, Dinesh sir, and Ravi sir for the inconvenience. It just take 5 minutes. Hello? Am I audible now? Hello?
Better than earlier, ma'am.
We really apologize for the inconvenience and the delay. So we'll resume the session. With due respect, Syed sir, Dinesh sir, and Ravi sir, should we proceed with the presentations?
Hello. Actually, now I got the link. That was not working. Can you hear me now? Can you hear me now?
Yes, sir, we can. So should we start with the session?
Yes, please. Actually, I just now got the link earlier. I could not get.
I'm really sorry. So we tried to send it, but there was some technical issue with that. We apologize for that. Can we start the session today, sir,
Yes,
now?
yeah, yeah.
I
I
would
think
request
one
Arun.
session already over. One presentation is already over.
I know, sir.
Link
So,
open.
no, sir, we have not started. I would request Arvind and Kushwa, sir, to please share the screen and start with his presentation.
I will evaluate from the slides later on. You please continue.
Sir, this is the first session we'll be
Okay,
starting with.
okay,
So,
okay.
yes. Arvind, sir, please share the screen. Arvind, sir. Yeah, please share the screen, sir. Please present. And a Google link is being sent to all the chairpersons. They can evaluate the participants over that with their registration ID. I think 179 is the registration ID for Dr. Arvind Singh Kushwaha. Arvind sir, should we share your slide?
Please share my slides because I can't, access my laptop's this thing. So I'm
I'll
on
do it for
mobile.
you, sir. I'll do it, sir.
Yeah, please. Yeah. Good afternoon, everyone. I'm Dr. Arvind Kushwaha from AIMS Nagpur. I'll be sharing my experiences while being in the army for 28 years, where we practiced public health in the field as well as the peace. Next slide, please. Next slide, please. Yeah. So basically, army environment provides very, you can say, conducive epidemiological mosaic for all the diseases which may be infectious, non-infectious in origin. It may be stress disorders, and main, burden is contributed by the non-enemy action injuries. Next slide, please. The environmental sanitation is definitely compromised, and food hygiene, the disposal of waste, because everything has to be ad hoc. We don't have any permanent stations like that while working in op environment. The sewage disposal is also unsatisfactory by means of only maybe shallow trench latrines, deep trench latrines, and maybe boreholes. These kind of things we have to. And environmental hazards constitute a major health risk, which includes snake bites, which may include falls from different places. Next slide, please. This is one experience, one of the experiences which I want to highlight as one of the public health interventions which was done. And this was in 2005-6. There was an outbreak of meningococcal meningitis in the troops, in the soldiers. And we, with the available resources, without any vaccine, could manage to control this outbreak to only a very small number, that was 17 cases with only 2 deaths. And this outbreak was almost ran over about 4 to 5 months. And if had it been any other situation, maybe any epidemic situation anywhere else, with a population, baseline population about a lakh plus, this would have actually gone on to cause at least 1,000 cases, 500 to 1,000 cases, and maybe with a case fatality rate of about 15%. Even with the best of treatment available, we could have had 50 to 100 deaths. But with very active public health interventions, I was the station health officer there, and we could prevent so many deaths, and we could control it to only 17 cases and only 2 deaths. So this is one such example which I had. Details are available in one of the published papers which is there. I don't want to go into details, and I'll go on to the next intervention that we had made. And this was regarding the suicides which was happening in the soldiers, and these suicides were happening too many, and it became a kind of a media sensation and also a parliamentary question. And there we designed intervention for the reduction of suicides in the soldiers, and this was named as Project Milap, in which basic aim was to bring about behavioral changes and recognize the susceptible soldiers who are likely to commit suicide by easy identification because of early clinical features. And we launched a massive intervention plan from 1st May 2006 in phase wise, phase 1, phase 2, phase 3, in which firstly we trained the officers which were trainers, and second, these officers who got trained went on to train their soldiers, and in the third phase we also trained the peer educators, and we could bring about a massive reduction in the suicides, with only 2 suicides in that year compared to 19 and even more in the previous years, and thereby achieving a huge success in reduction of suicides. Next slide, please. So this was Project Milab. Yeah, this I have already told. Next slide, please. Yeah. Next was an outbreak of gastroenteritis which took place in the civil population in 2010, and almost 2000 cases were reported. We went to investigate the outbreak, and we came to know that there was a kind of a contamination of water supply in the civil setting, and through that the outbreak went on to spread in the civil population. We made sure that our soldiers remain safe, and we designed intervention for them that they do not catch this infection, and we could achieve no single case in the army population which used to interact otherwise with the civil population very regularly. Next slide, please. This is the fourth experience of reducing the burden of viral hepatitis or jaundice in our soldiers, and it was seen from 2008 onwards. There was almost incidence of 250 plus cases, ranging up to 454 cases in 2011 when
I'm sorry, sir. I have to move to, sir. The time is over. Time is over. So I request you to conclude it, please. Unmute yourself, sir. Arvind, sir, please unmute yourself.
Okay, can you hear me, sir?
Yes, sir. Please make the final conclusions.
Yeah, this is the final slide in which we reduced the incidence of viral hepatitis from almost 450 in a year to just about 80 by investigating each and every case, and we found that most of the cases were getting infected during the transit from during leave, and that is how we intervened, and we made sure that they were given a water bottle and a disinfecting chlorine tablets, by which we could reduce the incidence of viral hepatitis. And that's the last slide, please. Next slide. Thank you very much. And the public health as such in Army is a major thing which makes a lot of difference because in the operational readiness of the soldiers. Thank you very much, sir.
Thank you, Arvind, sir. I would request the chairpersons to please the floor is open for questions.
Yeah, please.
Thank you for sharing your army experiences, long experiences for reduction of burden of diseases. Please tell me something about your Operation Milap.
Sir, Operation Milab was launched I was there in the valley in Srinagar when we started getting many cases of suicides in the formation. And that is when the commander there, he directed that we need to do something about it. And I, along with one of the psychiatrists there, we formulated a plan under which, we had to kind of educate these people that suicide is preventable. First of all, most of the people there, even in general public also believes that suicide is something which has to happen. It's like accident. No, it's not an accident. Most of the suicides can be prevented. And that is the first thing that we had to kind of break the ice with the commanders and the Javans, that suicide is preventable. You can identify people with behavioral patterns which can be well identified, and they can be intervened, and we can make a difference. So we launched it in 3 phases, and we could reach every soldier, we reached every Jawan, every commander, and we could educate them on suicide. How does it, the pathophysiology, what are the features, and early identification, we could reduce the suicides to a large extent.
Thank you.
Good afternoon, Dr. Arvind.
Thank you, sir.
Good afternoon, Dr. Arvind. Are you?
Good afternoon, sir. Good afternoon.
It's very informative information. And just one query: what sort of article you determined it to be, and how is going to plan with it? What's your next move?
Sorry, I couldn't get your question correct.
I'm asking what's the sort of article it was, and what's your plan for your coming days for this
As I have mentioned in the opening slide, that these are the snippets of my experiences in the army for last about 2 decades, and that's why I have deliberated on 3 or 4 such instances which bring about the evidence that public health interventions can produce. That's the main take home. It's not one single kind of a paper or a kind of incidents which I have mentioned. As I mentioned, the 4 or 5 experiences which I had, and each produced a particular outcome or a result or impact in terms of public health interventions.
Okay, thank you.
Thank you, Dr. Aravind. That was a very interesting talk, and I feel like going and exploring more of this kind of experiences that we have in our country. Thank you for that.
Thank you so much.
One thing I want to ask is, you have shared some of your experiences. Can you tell me what are the public health functions that primarily helped in succeeding with these interventions? Like, is it surveillance? Is it behavioral change, communication? In that way, what would be the important public health functions that could be scaled up based on
Right. I'll just tell you. For example, I think when it comes to infectious diseases, surveillance is definitely of prime importance. That means you should be able to predict, you should be able to catch very early when the incidence is rising and why it is rising. Once you find out about the reasons for the rise, you can make interventions suitably designed for that. And as far as the non-communicable diseases like suicides, as I said, once it becomes a kind of a political agenda for your administrators, then obviously you can suitably intervene and design certain interventions. Like we also did similar interventions for suicides as we did. We also did for non-communicable diseases because of the sudden deaths were happening. And with that, lot of undetected diabetes, undetected hypertensives, with lot many risk factors which were undiscovered were all detected, and we could bring about even reduction in the number of sudden deaths in our formation. In fact, there are lot many such experiences with each tenure that we have. So surveillance plays a very important role. And then comes the second thing is designing an intervention based on your investigative modalities, public health investigative modalities, why the thing is happening. So basically, it's a public health approach to a problem. What exactly is the problem? What is the extent of the problem? What is causing the problem? What can we do about it? What is the feasibility of intervention? And then, of course, with the army, the biggest advantage is whatever you think of making an intervention, the administration is there to support you. So that is the biggest advantage that we have, and that is why we often succeed in such settings. Thank you, sir.
Any more questions, sir? So when we proceed with the next presentation, I would request Dr. Pramod K. Gupta, sir, to please share the screen and start the presentation.
Thank you, sir. Thank you, everyone.
The registration ID for Pramod sir is 163.
Pramod sir, please share your screen.
Trying to share it. Yes, please. You are visible. So Pramod, you can go ahead. We can hear you. Please go ahead.
Yeah, I am trying to share the screen, sir.
Pramod sir, should we share the screen? Should we
Yeah,
share your presentation? Will that be fine?
please. Yeah, you can.
In the meantime, if not visible, you can take another speaker, another presentation.
Should we move to another
Yes,
participant?
please.
You can share my screen,
Sir, I'm
Dr.
sharing
Dorika.
this. Yes, sir,
Yeah,
I am
please.
sharing the screen. Just give me a moment, sir. I am just. Pramod sir, I guess you have not shared your PPT with us. I would request Dr. Ayushi Rastogi to please take over the presentation. By the time I request Pramod sir to please email our presentation or WhatsApp as soon as possible, we'll put it.
Okay, thank you, ma'am. I'll just share my PPT.
The registration ID for Dr. Ayushi Rastogi is 172.
Yeah, so is my PPT visible?
Yes.
Yeah, I
Your
would.
PPT, please share your PPT.
No, Dr. Ayushi. You please share the screen.
So is it visible now?
Yes, yes.
Yes.
Okay, okay. So good afternoon, everyone. I'm thankful to the Eficon for giving me an opportunity to present my research work. The title of my presentation is Prevalence of Non-Alcoholic Fatty Liver Disease in New Delhi, a committee-based study. I'll be presenting a pilot study that has been done in one of the RWAs to assess the feasibility of the study. So the outline of my presentation is background, objectives, methods, results, conclusion, and references. Uh, just to briefly touch upon the background, NAFLD is a public health problem with prevalence ranging from 8.6% to 86.8% in India. It is a life-threatening problem not because of its burden, but rather its asymptomatic nature in early stages, which progresses to poor and severe clinical outcomes in later stages, such as liver cirrhosis, liver transplantation, where the treatment modalities become limited as well as expensive. Thus, an early detection is the key to prevention. Early detection of NAFLD helps in early management of the disease by preventing its progression by simple lifestyle modifications like modifications in diet as well as increasing the physical activity. However, to plan any kind of intervention, we need to have the accurate burden or true burden of the prevalence of the disease. However, there is limited data available about the community-based prevalence and risk factors associated with NAFLD. With this background, our objective was to assess the prevalence of NAFLD in selected resident welfare association in Delhi and to explore the risk factors associated with the NAFLD cases. To cover these objectives, a community-based cross-sectional study was conducted using a mobile screening van from March 2019 to April 2019 on Sundays. All the adults living in the selected RWA were invited to volunteer for the study. Those adults who visited the mobile van during the camp timings in 8-hour fasting state without any liver-specific symptoms or known liver diseases were included in the study. The mobile van, which you can see in the picture, had the facility to carry out all the medical examinations, blood sample collection, and fibroscans, and had a trained research team. The trained research team collected the data based on STEP survey, anthropometric measurement, blood pressure assessment, blood sample collection, and fibroscan was also done
to collect the data on necessary parameters and risk factors associated with NAFL. The data was analyzed in Stata software. So coming to the results, we interviewed around 105 participants based on 4 visits made by us. However, we had data about only 95 individuals for FibroScan. So based on that, only 95 individuals were analyzed. Based on the FibroScan value, we took a cutoff of 6 and above for considering them to be fibrosis. So we had 23 in one group, that is with fibrosis, and 72 in non-fibrosis group. Among the fibrosis group, one was found to be viral hepatitis positive, and 2 were having excessive alcohol use. So these 3 individuals were not considered to be having NAFL, and only 20 individuals were considered to have NAFL, and 75 were considered to have non-NAFL. So based on this, our analysis are as further. So first, coming to the baseline table, we had around the mean age of the participants was around 52.84 years, with 57.3% being males and around 76.7% belonging to social class 1 as per the BG Prasad classification 2019. Now coming to the association of risk factors with NAFL, waist to hip ratio was found to be significantly associated with NAFL with an odds ratio of 3.17 and p-value of 0.03. Physical activity was found to be moderately, marginally associated with NAFL. Coming to the other risk factors, history of raised cholesterol, metabolic syndrome, raised ALT was found to be significantly associated with NAFLD. However, history of diabetes was found to be marginally associated with NAFLD. Just to sum up the slides, the prevalence of NAFLD was found to be around 21.05% with a 95% confidence interval of 13.4% to 30.6%. Waist to hip ratio, history of raised cholesterol, presence of metabolic syndrome, and raised ALT were found to be significantly associated factors with NAFL. Physical activity and diabetes mellitus was found to be marginally significant. The study could not get significant association with BMI and other risk factors pertaining to its small size. However, we were able to assess the feasibility that this kind of study can be undertaken in community, and a bigger study we are planning to once the situation gets better. So these are my references, and thank you for your attention.
Thank you, Dr. Ayushi. I would request all the chairpersons to please, the floor is open for questions.
Good afternoon, it's Rastogi.
Good afternoon, sir.
It's a good presentation.
Thank you, sir.
However, I need to know which type of sampling method you have used in this committee-based study you have made.
Sir, as I mentioned that it was a pilot study, we did not use any kind of sampling method. That rather it was more of a non-probability sampling. You can say that the convenience sampling. The individuals which were coming to the clinic, to the to the mobile van were included. So that's it.
Okay, and what's the take-home message?
The take-home message is these kind of studies are possible if we have a well-trained research team, and we have all the parameters, all the SOPs in places, and the prevalence which we could account from the study was around 21%. A larger study can be done to confirm these factors, which we are actually planning once the COVID situation is slightly better.
Okay, thank you.
Thank you, sir.
Thank you, Ayushi. You have done a good study.
Thank you, sir.
Pilot study only, though.
Yes.
I want to know what are the sources of bias in your study and how to increase the external validity of this study.
Sir, can you just repeat the question? Sorry,
What
sir.
are the sources of bias and how to increase the external validity of your study?
Okay, sir.
What methods you will take?
Okay. So the first and the most important bias was the selection bias. As you can see that, like even the FibroScan, which I said now, like even the 105 individuals that we have interviewed, however, we could not do around 10 individuals. We did not have the data because they were slightly obese, and obesity is one of the factors for accounting to be the risk factor for NAFL. And for since we had a fibroscan which could not be, because of their muscle mass, we could not actually assess for the NAFLD among them. So that could be one. Secondly, those people who turned up for the camps were more health conscious, and maybe they could have been involved in better risk factors. Secondly, third bias could have been account social desirable responses. Alcohol assumption, alcohol or the audit score that we use could have been slightly underestimated in the population. So these are the three biases which can be done.
One more question, please. Brief answer.
Yes.
What is the gold standard in your case? How you have diagnosed NAFL?
Sir, I have used a fibroscan. We have actually fibroscan for assessing the fibrosis. We have taken a cutoff of 6 kilopascals as the LSM, liver stiffness parameters for that. However, the gold standard is biopsy, but we could not do the biopsy as it is not practical in carrying out in.
So can you say the prevalence? Can you say the prevalence rate?
Sir, because sir, as per the other studies which we are, it's not the sensitivity and specificity are not so bad that we cannot say that it is prevalent studies. Yes.
So, Ayushi, those who were positive, what was your action? Like
So
you
yes, sir. Those who were one was found to be hepatitis C positive. We actually asked them to visit the ILBS, and we provided them care for that. The treatment is still on going since he did not achieve the SVR in time. Secondly, the alcohol, we provided them counseling, psychological as well as counseling to the family. In addition to that, even the people who were not found to have fibrosis but were found to be obese and they were having high BPs, we tried to provide health education to them as well so that we can prevent these NCDs in coming years. So.
Please go to the next presentation.
Thank you, sir. Thank you, sir. Thank you.
Thank you. Thank you, Dr. Ayushi. I would request Dr. Pramod to please start with the presentation. The registration number for Dr. Pramod is 163, and for Dr. Ayushi Rastogi, it was 172.
Thank you, Dr. Gorisikha. Good afternoon, esteemed chairpersons. I hope my slide is visible now.
Very much, sir.
Yeah, sorry for the inconvenience. I got some firewall problem, I think, on my computer. That is why it got, some issue. The work which I'm going to share with you is the part of the project which intended for the, find the root cause or challenges, misuse of statistics in the medical research. So I'm not going to present the whole project. This is the part of the whole project. This project is sanctioned by ICMR for 3 years. The aim of the project was to, find the misuse or misinterpretation, inappropriate use of statistics, and we did this project. What I'm going to share today is about the survey experience. Data collection is a very important part, and when you do the field survey for the data collection, you got many challenges and you have to overcome with that. So that aspect I am going to share. So it would not be the usual presentation for the chairperson attentions that you get the very procedure or methodology, but of course this is the project, so we have a this is a cross-sectional or a cross-sectional study design, and we have all the methodology incurred in this project. But what I am going to share is the experience, and the objective which I said is to find out our individuals which required to assess the thesis, assess the information from those individual, or I can say thesis. So we have an object here and our aim to find out final year student or PG or PhD students and their thesis which they have submitted as a dissertation part of their degree from the library. So we want to find this one and we want to evaluate this on the basis of questionnaires so that we can generate the score and we can understand that what is the cause and what is the situation or circumstances faced by the students. So these are the area this project was carried out in the Punjab and Haryana and Chandigarh. Everybody knows our aim was to find out 1,000 theses and 1,000 residents and survey them. So we do the sample size and that sample size give us this number. So what we did, we took all the medical college of the Punjab and Haryana. I am skipping so many slides because I have a limited time. So we found the 16 medical college of the all these region, and we try to survey these thesis and students from there. And what data we have in our hand is these numbers. Like we have offline and online details of the their thesis and the number of their admissions. So we know the number of seats allocated to the medical college. So we found through the offline online method, and these numbers are given here in this column, intake of the colleges. So we know this number, we know this total number is like the total number was about 1,500, and we need to find out 1,000 students out of that. So we are very good situation here. This table shows 1,659 total number of intake in the one academic year, and we need a 1,000 students. So you see, we got the 60.28 proportion. We could get it. But what happened when we go to the field, and these I am going to discuss here and share with you, that when we go to the, to find out this student and thesis, we came to know that how the intake is not exactly what they are mentioned in their website or their offline details. There are, half of admission, like of 1,643, all the college together, but their admission vary academic year. So what the most challenging we found, that the total allocated seat, or I should say intake, is the half of that. So it disturbs our whole, procedures, and we have so many other complexities, which is written here as a challenge from challenge 2, 3, 4, and 5. So what we did, we tried to overcome with this situation. So what we did here, the first year we divide all the intake by 2 so that we can have a half number of theses. That lead to the another challenge, that we need to collect 2 academic year, because our required sample size was 1,000, but the available population of the thesis of a student is close to 1,000 or less than this. So that disturb our sampling proportions. So we adjust this one. Then we came to know that there is some colleges, they don't have a pass course, any PG pass student. So we discarded in the next stage. Then again we have to allocate the you know those students in the other colleges. So we have to reset the proportion. So the aim was that when we got our sample after all the survey, after completing the survey, does this data represent our truly represent our the
I am sorry, Dr. Pramod, you've crossed the time limit. I would request you to conclude. Kindly unmute yourself and please conclude. Sir, unmute yourself.
Okay, got it. So we try to do so many steps so that we can manage our distribution of the sampling within the population. So there are a lot of steps we have to follow, and finally we got our.
Sorry to interrupt, Dr.
Yeah, this is the final
please
slide.
come on conclusion.
Yeah, so that is the conclusion. Then we got, this, our finally we got this much thesis in 2 academic year, 4381, and we, after all the adjustment, got 1078 thesis done, which required 1000. And after all the oral, finally the student, we got 1672, and we were able to get 954 student interviewed. And we compare with the theoretical part, so we seen that we are not very far from, the theoretical distribution of the sample and whatever we have achieved. So after doing a lot of adjustment or practical complication, our innovation or our modification serve us the better. That is the whole story in this whole survey experience, which I will try to share it. So this is the take-home message, that based on this experience, is the irrespective to the your well-planned survey methodology in light of available information and knowledge experience, practical challenges made you to deviate from your theoretical setup. So you have to wisely use the alternative to come up with the right solution. That was the take-home message from this. Thank you, everybody.
Thank you, Dr. Pramod, but I would request all the participants to adhere to the time limit, because that is unfair to all the other participants, because we have a limited time slot and everybody have to complete their slides. And I would request, if I request to please conclude the session, please conclude the session, because that is really wrong on the part of other participants also. Thank you, and the floor is open for questions.
Pramod, I want to know whether the thesis you have evaluated or you have interviewed PG students, it is not clear and your objectives and findings do not match. And also want to know whether those theses were guided by statisticians or not. How many of them were guided by statisticians?
The first part was that, sir, the first question was, we make the required number. Of course, we like in the at the part of the interview part, means interviewing the final year student, and that was due to the time lag and this now all the geographical location we have to catch out. But we have a sufficient number to conclude part one. Number two, uh, it was very rare to see that they have a statistician as a guide in their thesis.
No
Means
guide,
they're hard.
even if they are not guide, they help in their statistical analysis. So blame goes to them also.
No, there are very, means we, this information we can only get through their acknowledgement page. There is no other source that we can get this information, and they take some help. So the percentage was like 1 or 2%. People who mentioned that they have taken the help of the statistician or they have been advised by the statistician. So very few people have such a perhaps they must say that the classes which has been given by the statisticians should be little bit more simple and elaborated.
My fellow chair, please. My fellow chair, please use also.
No questions. Please, next presenter.
Just make one statement. I just need to make one statement.
Yeah, please.
Was there any consideration to the speciality of the courses that the students were doing? Because some courses may have more data intensive thesis, while others, like which depend on imaging, data and statistical analysis may not be that important. Was that ever?
We consider all the subject taught approved by the Medical Council of India. So there are all sort of the students. But whatever you are asking, I don't have a specific answer for that, because I have not seen through this angle on this part. But everybody have a data that right?
Then we can go to next presentation.
Thank you, sir.
Thank you.
Thank you. Pramod, I would request to stop this screen share, and I would request Dr. Amit Kumar sir to please take over and start the presentation. And I would request you to please adhere to the time, sir.
Dr. Gorika, I am audible.
And the screen is also visible, sir.
So good afternoon to all of you. Myself, Dr. Amit Kumar. I am working here in ICMR National Institute of Malaria Research in Delhi. Sorry for my camera is not working, and so I'm just presenting now. And I'm just briefing about the how the means the parasites behavior against the particular type of treatment we are giving in a particular region into the India. So we are just find out the profiling of the parasites into the infected malaria patient in India. So as you know about the morbidity and mortality of the malaria, which have been increased across the sub-geographical region, and which are widely due to the widespread resistance into the country, and the complexity of the parasite and existence of the several polymorphism into the parasites are major hindrance for the malaria control program into the country. And the basic the profiling of the parasites in India will provide the useful baseline data for future studies elucidating the parasite structure and distributions of the drug resistance genotype in different regions into the country. So basically, we have chosen the three parts of the countries, like two endemic regions and one is non-endemic regions, Ranchi, Raipur, and the Mewat. From there, we have collected some samples. Like across the regions, we have collected 122 samples throughout the regions, like 60 from the Mewat and 40 from the Raipur and 22 from the Ranchi area regions. And these malaria infected patient samples, we have characterized their the drug resistance genotypes, their certain the gametocyte genes, which are helpful into the transmission of the disease. And we also analyze the in vitro drug sensitivity assay by the SMI assay, through which we find out how the parasite behaves against the particular type of drugs given into the treatment for the malaria. So that are the results through which we have to find out there's how the mutation in particular type of drug in genes we have find against the particular type of drugs which we are providing to treatment for the malaria infected patient into that regions. Like we have observed the CRT, chloroquine resistance genes, multi-drug resistance genes, and DHFR, DHPS genes, which are against the sulfadoxine pyrimethamine and against the ACT combinations drugs given into that regions. So basically, we have find that the mutant codon across the all the regions we have found it suddenly increasing as compared to the previous data we have observed in that like in 2009 to 10s. So we have found the regions for the mutant alleles in that particular regions we have found is slightly increased. And as you can see the how the SNP and their nucleotide diversities, like if you are talking about the pairwise difference in their alleles, so it's slightly increased. And certain type of test we have to done say to uh, set out of our studies. And like if you are talking about the particular genotypes in correspondence with the artemisinin combination therapies, so DHFR and DHPS drugs which are in given into the sulfadoxine pyrimethamine treatment in ACT. So we have found the certain types of means the mutation in that genes. So these are not means genetic similar. So these are mainly the clades are irrespectively different from the particular type of segment we have found there. So the particulars isolate has shown the different type of combination patterns there. So through which we have to find out there are certain type of mutations which are correlate with the drug resistance genes, and which means decrease the efficacy of the drugs against the parasites. So these are the DHFR, DHPS, and through which we another find another genes like PFG377, which are helpful into the transmissions of the malaria. Like it is the means that genes mainly helpful into the third stages of the gametocyte, which are the prior stage, which is the mosquito taken up from the blood meals of the host and infected to the other persons. So after analysis, we have to find that through the genes, we have found there are certain dissimilarity patterns. We have found a certain type of novel mutation into that and certain type of deletion, certain type of insertion into that. And so there are no particular type of patterns. We have found that there's three types of deletions or four types of deletions, like 21 base pair, 42 base pair, 63 base pairs, and 83 base pairs. So out of these, 21 base pairs are the most common type of deletions which have been found into that sequences. And we have found certain types of haplotypes into that sequence, like we have combined all the drug resistance genotypes into the PHG377 genes. So there are certain types of haplotypes. We have found the wild type haplotypes is near about the 36% as compared to the like A9 and A10s, which are most significantly found into that sequence. And through the efficacy, through the in vitro analysis of the drugs, we have to found as the means the in vitro.
Please conclude.
I'm sorry, Dr. Amit, please conclude. You have unmute yourself and please conclude your cross.
Okay. So through the conclusion, we have to find the study mainly provide the information on the drug resistance phenotype, which are critical role into the play of the malaria transmissions, and increasing the mutations rate in particular type of genes or codons, and the existing diversity in the CRT MDR genes. Throughout the increase, there's the IC50 inhibitory concentrations for the particular type of drugs, like artesunate and chloroquine into particular regions. There's and the emergence of the drug resistance genotypes needs to be tackled by the multi-prolong approach, like continuous surveillance, and to access the resistance of the dynamic and the surveillance of the molecular markers by the drug resistance is essential, as it help in selecting the most effective treatment and also should help in the malaria interventions programs here. So thank you for your attention.
I would request all the chairpersons, the floor is open for questions.
Mr. Amit, good afternoon.
Yeah, good afternoon, sir.
Any similar studies you have seen so far so that you can compare your observations?
Sir, we have to previously done say in vitro analysis study there. So we have to find if the resistance will increase, resistance has been increased, then there the efficacy of the drugs for particular type of drugs has been decreased there. So we have find there are certain type of mutations and which influence the drug resistance pattern into that particular area there.
Okay, so what you find, what could be the reasons of this? It's a general question.
Sir, it
What
means
are reason for mutations?
it's there are different cause for that. It may like be due to the drug pressures there's and due to the peoples are not following the not complete the drug treatment there's. So there are certain cause to be increasing the mutation in particular area or region, and some other factors like increasing the burdens of the like parasite surveillance rate also there's.
Any reason relating with change in environment or global warming or something like that? Have you have come across in any other studies?
No, sir, we didn't have that.
Okay, thank you.
Thank you, sir.
So please go ahead from my side because we are lacking the time. We have to compensate everything.
Yeah, I too cannot ask much because this is really outside my area of expertise. However, I'd like to know the feasibility of tracking spatial patterns with this kind of data. Spatial patterns of emergence and resistance.
Sorry, sir, your voice is not properly audible.
Spatial distribution of resistance, can we make that out from this kind of studies and data? Like which part, what kind of resistance is there? Is the epidemic, is the resistant bug moving from one part of the country to the other in a certain pattern? Would
Sir,
such
mostly resistant. Sorry, Mostly resistance is common in all over India. Like if you are talking about a certain type of drugs, like if you are talking about the in correspondence with the ACT, like if you are providing their sulfadoxine-pyrimethamine, then we have find a certain type of study. So they reported the certain type of codons mutations in particular area, like 59s and 108 are the most common predominant in all over India. So they are specific type of pattern, but somehow we find that there are certain novel type of mutations which are correspondence with the resistance to a particular drugs. There's
Yeah, my concern was that whether we could use this data to predict changes in vector patterns, vector bionomics, or even treatment patterns, whether these could be used to that.
Yes, sir. We have already submitted this means our the profiling of that sequences into the like NCBI and some others, and we have to report into the ICMAS for that case. We have to find a specific type of pattern into particular area there. So maybe it will helpful into the like implementation of the another program there. So it's depend upon the means what they are thinking of the policy makers. Okay, thank you, sir.
Thank you, sir. Thank you, Dr. Amit. The registration ID for Dr. Amit Kumar is 149. You can accordingly mark them. And I would request the next participant, Dr. Chaya Singh, to please take over and start her presentation. And I would request Dr. Chaya to please adhere to the time, and I'm requesting this to all the participants, please.
Please, no voice.
Dr. Chaya, you're not audible to us.
Please unmute Chaya. Please unmute yourself.
Dr. Chaya, you're not audible to us.
If not, then we can.
Dr. Chaya, I guess there's some technical issues. We can take your presentation next. I would request Dr. Sitendra Saraswat to please take over the presentation. Dr. Chaya will take over your presentation. Don't worry, we'll get your presentation done. And the registration ID for Dr. Sitendra Saraswat is 121.
I'm sorry I'm interrupting, but ma'am, I cannot present when someone else is already sharing.
Yeah, I'll do that. Dr. Chaya, please stop sharing. Please, Dr. Saraswat, take over.
Sure, ma'am.
I again repeat, the registration ID for Dr. Saraswat is 121.
Ma'am, could you please confirm if my slide is visible
Yes,
and I'm audible?
yes. You're perfectly audible. The slides are available.
Thank you so much, ma'am. Very good afternoon, everyone. My name is Dr. Satyendra Sarswat. I'm here to present my topic, bacterial flora on the mobile phones of the healthcare workers of the microbiology department of UPMS CFI Itawa, Uttar Pradesh. Talking about the introduction, as we all know that despite upgradation in the healthcare services, hospital associated infections or healthcare associated infections still affect the healthcare. Mobile phone is a potent reservoir for all the pathogens which could lead to serious infections and thus affect the health standards. And it is also well known that mobile phones are rarely cleaned. They are often touched during or even after handling the specimens in the laboratory, and sometimes even without washing. The objective of this study is to isolate the different types of bacteria found on the mobile phones, all the surfaces, edges, margins, the speaker region, and as nowadays the mobile phones have become a part of each and every aspect of our life, including banking, gadgeting, and even the presentations, as in this Eficon. So I would like to isolate. What I did was I isolated them. Another objective was to identify these different bacteria and to assess the antibiotic susceptibility of these organisms grown on the mobile phones. Materials and methods used. The samples were collected using cotton swabs by rolling over the exposed surfaces of the mobile phones, including the camera, including the front sensor, the margins, the speaker area, these and of course the screen, the touch screens, which is overall mostly used. These swabs were then inoculated on the agar plates and incubated aerobically. After incubation, the plates were examined for the growth. These bacteria and were then identified as per the standard microbiological procedures, and the antibiotic susceptibility profiling was results. Now, talking about the results, we had overall 80 samples. 40 of them were from the healthcare workers, and the rest of the 40 were from the non-healthcare workers. Out of them, we isolated around 64 bacteria from the mobile phone of healthcare workers. 17 bacteria, however, were isolated from the mobile phones of non-healthcare workers. Talking about the organisms identified in case of healthcare workers, Staphylococcus species was identified to be the most predominant species, further followed by the Pseudomonas species in case of healthcare workers. Uh, the bacterial distribution has been laid down in this table. In this, we can see that in case of healthcare workers, the maximum number of organisms identified were 10 in case of Staphylococcus aureus and Coagulase negative Staphylococcus aureus, 4 cons. So both of them compile up to 14, which was the maximum in number in case of healthcare workers. However, here I would also like to indicate that ASBs, diphtheroids, and micrococcus are usually considered normal commensal, so they have not been taken into consideration as pathogenic potential organisms. The total number of organisms identified in case of mobile phones of non-healthcare workers had maximum numbers of Pseudomonas isolates. The organism Pseudomonas species, which was 4 in number out of the total 17 overall recognized. Talking about the antibiotic susceptibility profile of the cultures isolated from the mobile phones of healthcare workers, we can see then that in case of Staphylococcus aureus, most of the strains were easily susceptible with most of the antibiotics, but we can clearly see that there is a certain resistance which we can see in case of gentamicin, in which only out of 10, 9 isolates were susceptible. Ceftriaxone, again 9. That means a bit of the resistance has actually started already. But most important is ampicillin and erythromycin is already at the lower end of the susceptibility, as I can see here. Likewise, as we see in case of cones, ampicillin and erythromycin have seen the lowest susceptibility as compared to the other antibiotics used for this group. When we talk about Pseudomonas in case of healthcare workers, we had cefepime showing resistance and ofloxacin showing resistance. Showing lower susceptibility. That means that organisms, Pseudomonas strains, which are resistant, which would be resistant to ofloxacin and cefepime, are on the rise these days.
Please conclude.
Dr. Saraswat, you've crossed the time limit. I would request you to conclude, please. Unmute yourself, Dr. Saraswat.
here I would like to conclude that there is a definite colonization on the mobile phones of the healthcare workers, which is a potential threat to everyone. These pathogens are capable of communicating and spreading the infections and transfer these disease-producing microbes. So to reduce the incidence of nosocomial infections, what needs to be done is that we need to implement hard the hand hygiene, and we also need to regulate and restrict the use of the mobile phone in the healthcare settings, not just in the laboratory. Thank you for your patient listening.
Thank you, Dr. Satin Satwat, sir. The floor is open for questions.
Dr. Satendra, although your study was confined only to bacterial flora, even then I would like to ask whether your study was post-COVID lockdown or before lockdown.
Sir, it was carried out. Sure, sir. I carried out this study in last year only, in the month of October and November. Thereafter, there was a slight transition, and plus, I would also like to add here that this is a smaller part of a bigger study. That means I have just taken into consideration the microbiology department in this, but my plan is to also include other departments, so that a comparative data could be assessed further.
Then I also like to know why are you ignoring multiple responses? There may be multiple bacteria in the same phone. You are ignoring multiple responses, only single bacteria, according to your result.
Sir, according to my result, I have taken into consideration only those organisms which are usually pathogenic. That means there are a group of organisms including micrococcus, which is a normal skin commensal, ASBs and diphtheroids, which are normal commensals in the upper respiratory tract. So I have excluded them from consideration so that the organisms which are actually showing the pathogenic potential in the field of microbiology, we do not deplete the focus from those organisms. As we can clearly see that certain resistance patterns are visible in their results. Thank you so much, sir. Thank you, sir.
Ravi, sir, any questions from you?
Did you look at which part of the mobile phone you're sampling from? Does that have any influence in the growth?
Sir, as there has been a transition in the phase when 10 years back we were more focused on the mobile phones which had buttons. So the studies which I have gone through, the samples were collected from in between the buttons. That was a more focused or more used area. In this over 10 years transition, what has happened is we have switched from button mobile phones to uh, touchscreen mobile phones. So the screens are usually easily swiped usually, but the margins, the corners, they are usually the focal places where there are concretions, where there is collection of aggregates, the potential pathogens. The maximum of the organisms which I found to be in the culture, which I isolated in the cultures, were from the edges of the front screen. And as I clearly mentioned in my during my presentation, that edges were taken into consideration properly, not excluding even the crevices of the camera and the speakers, because as multiple swabs were used to take the samples, I have seen that these corners had more number of organisms cultivated in the culture as compared to the screen, which was usually swiped on regular basis.
Dr. Satinder, what I understood is that your study is a comparative study.
Right, sir.
Healthcare workers and health workers.
Non-healthcare workers, precisely, sir.
So, what statistical measures you have used?
Sir, it is a cross-sectional. It is a cross-sectional study, and it is just convenient sampling. I have compared the data of the results of healthcare workers and non-healthcare workers.
Statistical tests that you have been performed while conducting
No, sir.
analyzing this study.
No, sir, I have not done any. I have just compared the actual figures of the results. That's it.
Okay. So there
and
must
plus, I would also like to add it here, sir, that it was a very small data. when I actually made comparisons, taking into account the groups of different several departments, the result would be more conclusive. That is why also I have not made a complete statistical analysis.
Try to have a large scale of this type of study, because it cannot be explorated to all. So you need definitely a good sample.
Precisely, sir.
Okay, thank you.
Thanks a lot, sir.
Thank you, Dr. Saswat. And the registration ID for Dr. Satain Saswat is 121. And now I would request Dr. Chaya to please take over.
Now, am I audible, ma'am?
Yes, you are. Please share your screen, Dr. Chaya.
Okay, ma'am. Ma'am, is it visible?
Yes, it is. And Dr. Chaya's registration ID is 143.
Okay. Good afternoon, everyone. My presentation topic is the defecation practices and associated factors in slums of the Lucknow, UP. According to the WHO, open defecation is the riskiest sanitation practices of the all. Every 20 seconds, a child dies as a result of the poor sanitation. 80% of the disease in developing countries are caused by unsafe water and poor sanitation, including inadequate sanitation practices. The practice of open defecation is not only limited to the rural India, but it is more prevalent in urban slums areas also, where the percentage of people who defecate in the open is very large. And according to the UNICEF 2019, the prevalence of open defecation is 34% in the India. The objective of this study was to understand the factors impacting on defecation practices in urban slums of the Lucknow, UP. Second objective was to study the prevailing defecation practices in the household in urban slums of the Lucknow, UP. And third objective was to assess the knowledge and attitude with regards to the sanitation practices in urban slums of the Lucknow, UP. Now, the material methodology, the study was the cross-sectional descriptive study, which was conducted in the household of the urban slums in the Lucknow city. And the participants was the adult members in the household of the urban slums of the Lucknow. And the study period was in between the September 2019 to the November 2019. And the sample size is calculated by taking the prevalence of 34% according to the UNICEF 2019 data, which was to be the 201. And sampling technique, the two-stage simple random sampling was done for this study. Now, this is the table number 1, which is showing there out of the total 201 households visited, there was a total 78.1% were the male participants and 21.9% of the female participants. And the educational status of the participants, around 50% of the participants were illiterate, and remaining 24.9% were the preschool and 24.9% were the middle school. And there was the 55.7% the participant were from the belong to the lower socioeconomic status according to the BG Prasad classification. Now, this is the table number 2. We showed that around 92% of the household have not present any toilet facilities. Only 8% of the households had an independent toilet in their houses, and majority, around 99% of the toilets didn't have an independent water connection. Hence, people had to carry water during use from the outside. Then the usual site for the open air defecation among the urban slum was the majority of 45.8% people use the railway track alongside gutter, and only 10.1% of the participants use the community toilets, and only 8% of their personal toilets. And the main water supply in the urban slum was the municipality water, which was 80.6%. Now, this graph number 1 is showing the reason for no toilet present in that area. Then majority 46% have given the reason that there is no space, and 24% had responded that they have no adequate funds for the toilet construction, and 21% had the other reason. And reason for not using the community toilets among these households, the majority were responded that 33% for that community toilets are very unhygienic. 22% found that the community toilets are very expensive for them. and 25% find there are so many other reasons for not using the community toilets. Now, the opinion of the participants about open air defecation is shown in these two graphs. 77% considered it bad, and 23% participant had good opinion about the open defecation practices. And the 41% participants found that the open defecation has a association with the bad hygiene, but merely 7% participants found that the disease caused by the open air defecation. And now 52% participant had the good opinion about open defecation. Fresh air is mainly associated for their opinion. And now the conclusion of this study is this is a large prevalence that 81.1% of the household in the urban slum is practicing open air defecation. Then it is a major problem in the urban slums of the Lucknow, and the reason behind is the lack of funds, space constraints, and customization to all habits are the main reason. And the government should focus. Government and public efforts have to be directly towards ensuring the availability and accessibility to the household toilets and adequate water supply to achieve the goals of open defecation-free India. Thank you.
Thank you, Dr. Chaya, for concluding this. And I would request all the chairpersons, the floor is open for questions.
Dr. Chaya.
Yes, sir.
How will you take this point that 92% of the respondents didn't have no toilets?
Sir, I had conducted a questionnaire, a WHO questionnaire-based study. Sir, then I asked every household, every participant I interviewed. So, sir,
you're just contradicting this
yes, sir.
Government claims of this defecation free.
Yes, sir. Actually, sir, it is, sir. But I had visited 4 slums of the Lucknow, and I had taken two slums, the Cis Gomti, and 2 slums from the Trans Gomti. And sir, I had I surveyed the Kacha slum of in all the 4 areas, and I had visited 50 household in every slum. But sir, unfortunately, sir, there are no toilets in these areas, sir. Only I think 16 households have the personal toilets. Yes, sir.
That's alarming figures. Need to be corrected by guys, usually, especially government. So 92% is a huge.
Yes, sir.
Because
yes, sir. It's very huge number, sir. But it is actually
apart from government interventions. So it
yes,
will.
Sir.
Okay.
And so, unfortunately, these are the registered slums.
Okay.
Dr. Chaya, really, you have presented a very gloomy picture and failing all government efforts, as my friend has mentioned. So, it is really to be checked. And you have to present the geographical location of these slums also. Because what was the reason why 80%, whether there was a bias selection of slums, or I am unable to.
Sir, there may be a bias, sir, because I had selected only the Kacha slum in that area. So maybe.
Railway line side, all?
Yes, sir. Pardon, sir?
Line track. Whether they were.
Sir, I'm.
Whether these slums
sir, your voice is
along the railway track.
Yes, sir. Yes, sir. These slums are located alongside the railway tracks, basically.
So you could draw conclusion accordingly, or specific to those types of slums. Even for slum population, results do not generalize for all types of slums. Okay.
Yes, sir.
Dr. Gaurika, I'm not. Who's the speaker? I can't see.
Dr. Chaya Singh is the speaker.
I just see Dr. Gaurika. That's why I said that. Sorry. Yeah, Dr. Chaya, if you were to do the study again, what additional variables would you consider adding to the study if you were to do it all over again?
Sir, actually, I had already, I had used the WHO questionnaire, which is also included the sanitation and hand washing and the demography, water sources, child defecation, and night soil disposal practices also. So, sir, but because of the limited time and limited slides, so I was not able to explain all these. Sir, if I will go further study, then I will include the water source sanitation practices and child defecation practices along with these variables also.
Got it.
Thank you, Dr. Chaya.
Am I audible,
Yes, sir,
sir?
yes, sir, yes, Dr. Chaya, and really thank you that you have really shown us a good, the right situation of India, even being a part of Swachh Bharat Abhiyan. We are not able to lead it. So I would request the next participant to take over, please.
Thank you, ma'am. Thank you, sir.
So I would request Dr. Nupur Kulkarni to please take over the session. Dr. Nupur, please. Dr. Nupur. I guess Dr. Nupur, please start. We are not able to hear you. There's a lot of disturbance and Dr. Nupur. Dr. Nupur, I would request you to stop sharing the screen. I would request Dr. Anjali to take over. You're not audible, Dr. Nupur. Dr. Anjali, please take over the session.
Yeah. Gorika, am I audible?
Yes, Dr. Anjali, you're very much audible and the
Good
screen is
afternoon,
also
all.
visible.
Good afternoon, all. The title of my study is Clinical Presentation of COVID-19, a Systematic Review and Meta-Analysis. So, as all we know, a pneumonia of unknown etiology reported on 31st December 2019 in Wuhan, China, which later termed as SARS coronavirus 2. The clinical presentation of COVID-19 varied in different settings and in different age groups. And COVID-19 can cause multiple clinical features, which include the respiratory, enteric, hepatic, and neurologic diseases, and which tends to be very severe in geriatric patients with especially with comorbidities. The spectrum of COVID-19 varies from asymptomatic or post-symptomatic to clinical conditions, which were very severe also. So this study was conducted with an aim to describe and document the varying clinical presentation and underlying comorbid conditions of the COVID-19 cases, with objectives as to assess the prevalence of various symptoms of COVID-19 patients and to assess the prevalence of comorbidities among COVID-19 confirmed cases. So this review adheres to the PRISMA statement. The various data sources and search strategy include the databases which are PubMed, Web of Science, Embase, elsewhere COVID-19 repository, and the research papers in the Lancet and BMJ COVID-19. And these were searched for publications up to 5th May 2020. We used combinations of medical subject headings and free text words that included the search terms related to exposure like novel coronavirus 2019, COVID-19, SARS-CoV-2, clinical features, clinical manifestations, clinical characteristics, and the search terms related to the outcomes like ICU care and mortality, etc. The search is concluded by 10th May 2020, and two different researchers independently evaluated the search results. So the eligibility criteria for the studies, we included all the published articles that reported the real-time RT-PCR confirmed SARS coronavirus 2 cases with demographical and clinical features. The various study designs we include the retrospective studies, cohort studies, case series, cross-sectional studies. And we excluded case reports, review articles, and opinion articles. The article language limit was not set. We included the publications from 24th Jan 2020 until 5th May 2020. So two reviewers, myself and my guide, simultaneously screened the results of the initial search strategy by title and abstract. The full text examined for inclusion and exclusion criteria, which we already seen, and the data extraction was done on the information on the study author, study area, year of publication, data source, age and sex of identified cases, study settings and reported signs and symptoms other than comorbidities, and mortality. And these data were extracted were independently performed by two reviewers, and the observational studies that reported the proportion of symptoms and risk factors included for meta-analysis. This is the Prisma flow of study selection. Firstly we screened 300 studies and excluded 170 because they did not meet the inclusion criteria. So from 130 papers, we excluded 45 further as they didn't have enough data on the clinical features. And from the 85, we further excluded 35 because appropriate reanalysis of longitudinal data was not possible. And 50 studies, again, we further excluded 5 case reports. And the final study, for the final analysis, 45 studies we included. So the results, the total study participants were 6843. The majority were males and included all the age groups from pediatric age group to geriatric group. And one study who Z et al. Was in the hospital and community setting, while the rest of the study were conducted in hospital based only. So among the 45 studies, 43 assessed the respiratory symptoms and remaining 2 reported the GI symptoms of COVID-19. So this is the table which represents the clinical characteristics of COVID-19 patients. Here we can see more than 3/4 of the patients. The pool prevalence is 75.1%. More than 3/4 of the patients had fever with 95% confidence interval between 74.1 and 76.2. And more than half of the patient had dry cough. 65.2% with 95% confidence interval between 64 and 66.4. And more than 1/4 of the patients had myalgia and shortness of breath, that is 27.5 and 26.3% respectively. And the least common symptoms include the hemoptysis and dizziness. So here the table represents the risk factors or comorbidities associated with, included in studies on COVID-19. Here we can see around 32% had obese or overweight, and around 16.9% had hypertension, and diabetes was around 7.9%, and respiratory symptoms other than COPD, 10.9% of participants had, and the COPD, which included only 1.8%. So the conclusion,
Sorry, Dr. Anjali. Dr. Anjali, you can unmute yourself. I muted yourself. Go on with your conclusion, please. Dr. Anjali, unmute yourself.
The most common symptoms were fever, cough, and myalgia, but fever could be absent in a significant proportion of patients at initial presentation. Frequently associated comorbidities were hypertension, diabetes, and respiratory diseases. Hello?
Yeah, go ahead, Dr. Anjali, you're audible.
Yeah, but I couldn't move the next slide. The limitation of the study, I just want to.
Just to speak up, what are the limitations?
Yeah, sir. The methodological quality of studies was not assessed considering the availability of limited evidences, and data regarding the ICU care, mortality, and discharge rate is also inadequate because of the cross-sectional nature of the studies. So, and we could not find the data regarding the symptoms like very recent symptoms like anosmia and loss of taste also. So that study was included till 5th May only. So that was we couldn't find any studies regarding those symptoms, and we missed that symptoms. Thank you, sir.
Thank you, Dr. Anjali. The floor is open for questions.
Dr. Anjali,
Yes, sir.
So, is it this is a recent pandemic, COVID-19?
Yes, sir.
So don't you find that your study period is so early and so limited?
Yes,
You can
sir.
extend it
Yes, sir.
further
I
because lot
started
of
doing in
changes
that
has been
initial
lot of
period.
has been made.
Yes, sir. It was concluded late, earlier, sir. I started doing the initial period itself.
You can wait for and can extend your study period and can
Yes,
come
sir.
up with the results in the coming months. So
Yes,
that
sir.
would be more rational.
Yes, sir.
Yeah, I actually fully agree. The meta-analysis which you have presented made the change with time, because nowadays we are getting more COVID cases who are asymptomatic.
Yes, sir.
So results might be quite different. So there is
Yes, sir.
need of
Yes, sir. Sure,
update
sir.
to your meta-analysis.
Sure, sir. So I will definitely do, sir.
You should not confine only to early stages of COVID up to May only. And
Yes, sir.
I don't think there is any problem of updation of results.
Yes, sir.
Anjali.
Yes, sir.
What is that column I square you had, right?
Yeah, sir. That is a measure of heterogeneity, sir. We used to find the different studies whether there will be a heterogeneity or not. And it is like if it is 0, then it is no heterogeneity, we can say. If it is 0 to 25%, we can say ki there is a low heterogeneity. And if it is 25 to 75, moderate. And if it is more than 75, and it is very high heterogeneity. Here we can see in the fever itself, it is around 79% or something, which is like high heterogeneity only.
So one of the participants has a question. Dr. Ayushi has asked, which model did you use pertaining to heterogeneity in your data? How did this heterogeneity inform your analysis?
Sir, is it that random effect model, sir, or fixed effect? I'm not sure about.
Which one? Which one of these? What? Are you sure? Fixed effect or random effect?
Random effect model is used to find the pool prevalence with 95% confidence interval, sir.
Please, next presenter if someone left.
So, yeah. So,
Thank you,
Dr.
sir. Thank you,
Ayushi
sir.
and Dr. Anjali can discuss this and let us know later on. So we can move to Dr. Nupur. Dr. Nupur, is it fine? Dr. Nupur, please share the screen. And I would repeat, Dr. Anjali's registration ID is 430. 430. Dr. Nupur, are you there? Can you hear me? Dr. Nupur? Dr. Nupur? Dr. Nupur is not here. Dr. Nupur, are you there? Just a moment. Dr. Nupur, can you please share the screen and start with your presentation?
Hear me?
We are, Yeah, please, you, Dr. Nupur, you please start the presentation. We are already running late to the
Yes,
time. Please restrict to the time.
yes, ma'am. Is it possible for you to share my PPT, ma'am, if you have? Because I've been doing it from the phone.
Dr. Nupur, we are sharing your, we are sharing the screen from here. You please continue.
Yes, ma'am. Thank you, ma'am.
I hope the screen is visible to everybody. Dr. Nupur's presentations are visible on screen, please. The registration ID is 103.
So, good afternoon, everyone. I'm sorry for the technical problem. So, my topic for today is pattern of utilization of MGPJY insurance scheme in a tertiary care hospital in last 5 years. Healthcare costs, especially high out-of-pocket expenditure on healthcare, can have a devastating effect on the lives of low-income people. So, Mahatma Jyotiba Phule Jan Arogya Yojana is a Maharashtra government's initiative for making healthcare access to lower socioeconomic sections of the society. Formerly known as Rajiv Gandhi Jan Arogya Yojana, it was renamed on 1st of April 2017 as MGPJY. The scheme entitles 971 surgeries, therapies, and procedures, along with 121 follow-up packages in 30 identified categories free of charge. The 132 government reserved procedures are to be performed only in empaneled government hospital or government medical colleges. Ma'am, next slide. The beneficiaries of the scheme are those holding a yellow ration card, orange ration card, Antyodaya Anna Yojana ration card, and Annapurna ration card. Also, farmers with white ration card along with Sat Bara, we call 7/12 extract bearing the name of the beneficiary, head of the family, or certificate from the concerned talati with valid photo ID proof. Next slide, ma'am. The features of this scheme are that the sum insured is rupees 1,50,000. Period of insurance is 1 year. Run-off period is 1 month cash, and it is a cashless transaction. The online claim settlement, so for all hospitalization expenses up to rupees 1,50,000 per family per year on a cashless basis are covered. This can be availed either individually or collectively on a floater basis. The insurance company will settle the claim online within 15 days on receiving the complete claim and other necessary documents, and will honor the claim for 1 month after expiry of policy period. Next slide. So we aim to study the pattern of utilization of MGPGY insurance scheme in a tertiary care hospital in last 5 years. This is a hospital-based cross-sectional study. The study sampling technique is universal sampling. Study duration is from calendar year to January 2015 to December 2020. Records of all MGPGY cases were retrieved from MGPGY department over a period of 5 years. So parameters analyzed were total number of cases registered, number of pre-auths sent, approved, and pre-auths are nothing but pre-authorization process, utilization as per the category, number of claims sent, paid, and rejected. Next slide, ma'am. Okay, so we can see here that the trend of the patients is increasing over a period of last 5 years. So initially we had in 2015 2,937 patients. It has steadily increased up to 5,580 in the year 2019. So the number of patients registering for this particular scheme is increasing over the last 5 years. Also, as I said earlier, pre-authorization is a process by which an insured person obtains written approval for certain medical procedures or treatments from the MGPJY society or the insurance company. So the pre-auths sent for 2015 were 82.98%. Out of the total 2,937 which were sent, approved were around 82.98%. So you can see that maximum number of pre-auth sents were approved. Around in 2019, around 78.92% pre-auths were approved. This was observed. The similar findings were observed in a study conducted by Radhakrishnan A. So in claims, okay, so this, ma'am, before that, before the slide before this, yeah. So claims sent, paid, and rejected. Out of the 2,437 claims sent, around only 4.72 are rejected, and they are basically rejected because of document because the document provided are incomplete or the investigations are not provided. So in 2019, we can see only 6.49% claims were rejected, about 93.48% were accepted. So now what we can see here, ma'am, next slide, the percentage of category wise.
Dr. Nupur, you have completed your 5 minutes. I request you to move to the conclusion, please. We are opening the conclusion slide here. Please unmute yourself and move to conclusion.
Yes, ma'am. So in my concluding slide, I would like to say that in last 5 years, there has been an upward trend in the number of patients registering for this scheme. Out of the total pre-auth sent, 82.92% were approved and 97.42% claims were paid by the government. So patients also registered in the scheme from the OPD, but as many diseases presenting only in the OPD are not covered under the scheme. Hence, their pre-auths do not get approval. So in recommendation, I would like to say that more aggressive awareness generation and marketing of the scheme is required. Another thing I would like to say is that my study revealed that the nephrology category was occupying the highest percentage, followed by polytrauma and pediatric medical management. In another study, they have said that orthopedic surgery occupies the major chunk, and in pediatric medical management, followed by in conservative management category, we have cardiology and burns. So I would like to recommend that more aggressive generation and marketing of the scheme is required for increasing the number of beneficiaries and increasing the number of categories for OPD and daycare procedures, and also for costly investigations. More such studies will be required for evolving strategies in the scheme for enhancing the health security among the underprivileged population. Thank you.
Thank you, Dr. Nupur. The floor is open for questions.
You have presented results from insurance perspective only. What about beneficiaries? Any opinion about them, and what was the average amount claimed? And you have sanctioned under the scheme.
Okay, sir. So you mean to ask about the total number of beneficiaries in last 5 years?
No, any difficulty faced by beneficiaries in getting their claim and average amount, if you have any idea.
Yes, sir. Actually, the problems that patients usually face here is the they cannot furnish the documents on time, sir. Many people have a ration card problem, so they have to go to the authorities and get the ration card made, or they have to retrieve it from somewhere else. Like that
Sorry,
is a
asking
problem.
what amount they have been paid. They got at the last.
Why there any difference between amount claimed and sanctioned amount?
Yes, sir. Out of those claims which are cancelled, sir, that amount they have to pay, sir. Patient has to pay if the claim gets cancelled.
That is not under cancellation. That is partly you have sanctioned the amount. That is not under cancellation. That is not called cancellation. Okay.
Dr. Nupur, the payment is made to the hospital, am I right?
Yes, sir. Yes, sir.
So if there is insurance coverage, then it's cashless service. Is it so?
Yes, sir. Yes, sir.
So usually studies like this look at issues specific to insurance, like say moral hazard. Did you consider looking at something like that?
No, sir. Actually, that was not part of my study.
Usually studies on insurance, health insurance schemes talk about adverse selection. Is there a possibility of adverse selection? Is there moral hazard? So I didn't find any such ideas coming out.
Yes, sir. Yes, sir. I'll definitely.
Yeah, and what is the scheme? Is it an insurance model in the state? Do you know about the scheme? Is it an insurance model or a trust model?
Sir, sir, it's an insurance model under the state. The state funds the entire scheme.
State funded.
Hmm.
This is a state funded scheme.
Yes, sir.
state funded scheme or any?
Yes, state funded scheme.
And are you aware of a concept called DRG, disease related group? Since you're working in this area, I'm asking you that. DRG, disease related group.
Oh, no, sir. I'll surely look into it, sir.
Thank you.
Yes, sir. Thank you, sir.
Well, I guess that was the oral session of 2020, last oral session of Eficon 2020. And I will just repeat the registration number of all the participants so the chairpersons can reevaluate if they want. Dr. Arvind Singh Kushwa, 179. Dr. Ayushi Rastogi, 172. Dr. Pramod K. Gupta, sir, 163. Dr. Amit Kumar, sir, 149. Dr. Chaya Singh 143, Dr. Satyendra Singh Saraswat 121, Dr. Nupur Kulkarni 103, Dr. Anjali M 1430. Yes, sir. And your coordinator for today, Dr. Goraka, I would request Dr. Syed Hassan sir to please make the concluding remarks.
Thanks, Dr. Gorika. It's a well coordinated event, and mostly all of them presented well with some little bit of tactical glitch. So it was really a nice contact with you people, with the presenters, and with the personals of this conference. I really congratulate everyone presenting over there and the one who have presented their slides. And best of luck for the others coming endeavors. Thank you.
Thank you so much, sir. A few words of wisdom from Dinesh, sir, please.
I add my voice with my chief chairperson, and there the session was prolonged a little due to some technical problems. But even then, there was a varied nature of presentations. In spite of all odds, we could complete it, and all presenters were quite encouraging, and they want to make modifications, and I hope they will make further incorporate for our suggestions in future and they will improve themselves. Thank you so much.
Thank you, sir. I would request Ravi, sir, to please give a feedback for the session.
I'm reiterating what Syed sir and Dinesh sir mentioned. As Syed sir mentioned, it's a huge effort. In a way, we have beaten COVID. COVID prevented the conference, but we did end up conducting the conference. All of you presented, and the organizers did a great job. So that's one thing. And as Dinesh sir was saying, the variety of topics is really interesting. From the conferences which I used to attend a decade ago, and the variety of topics, from that we have moved so fast ahead, and it's just so promising to be in this field, and it's very exciting. And I'm very grateful for the opportunity. Thank you.
Thank you so much, sir. And I, Dr. Gorika, signing off from Eficon 2020. It's the National Conference of Epidemiological Foundation of India. The validatory session has already been started in the plenary area. You all can join it. And to all the participants, the chairpersons have already logged your results in the Google sheets we have shared, and we'll sure share the results with you. Thank you, and have a great day ahead.
Thank you, ma'am. Thank you, sir.